Well, good morning, everybody, and welcome to this meeting of the Integrated Care Board for the North East and North Cumbria on the 1st of October 2024. I'll start with introductions and then move on to apologies for absence. Around the table this morning are two people who don't normally sit around the table: Anne Fox, Deputy Chief Nurse, and Leanne Furnell, Deputy Chief People Officer. And they're here because, as from the end of the month, they'll be taking over the responsibilities of our Chief Nurse, David Perdue, until his successor is appointed. And this is David's last meeting, so I'd like to thank you, David, for your work. You've been an incredible figure in that role at a time when a completely new function was being set up, but a very seamless assumption of the role, and the work that you've done, I think, has been greatly valued, not just by the board, but by people around the region. So good luck in your new role, which is in NHS England, where you'll be keeping a watch over us. So we look forward to ongoing contact. David Chandler's deputy, Phil Argent, is here as well as deputising for the Director of Finance. We have a number of apologies for absence that we'll record in the minutes, and then there are a number of people attending in capacity of members of the public. Move on then to declarations of interest. There'll be a number of declarations coming up during the course of the meeting, and we'll announce them when we come to the particular agenda item. I'll ask our Board Secretary, Dev Cornell, if we're quorate. We are, thank you very much. Then looking at the minutes of our last meeting on the 30th of July 2024, and our annual general meeting on the 30th of July 2024, to see whether there are any points of accuracy that anybody wanted to highlight. Okay, so we've agreed that the minutes are an accurate record. And on the action log and matters arising, first of all, are there any points from the previous meeting that you believe should be on the matters arising and action log? No. And then are there any items on the action log and matters arising that you wanted to discuss this morning or raise questions about? Thank you. And does anyone have any items of other business that they'd like to flag up now, and we can add them to the agenda? No? Thank you very much indeed. We come now then to the Chief Executive's report, and I'll ask Sam Allen, Chief Executive, to make that report.
Thank you very much, Chair. And my report's quite a long report today. I would just like to go through and kind of cover a few items in it. And I've also would like our medical director to give an update on paediatric audiology. Colleagues will have seen that this was covered as a national issue in one of the newspapers over the weekend, and I want to, Chair, ensure that members of the board are aware of the issues here in the North East North Cumbria and the steps that we've been taking with regard to that. So in my report, you will see that the NHS England assessment of the Integrated Care Board has been published. And I just really want to start by both recognising and thanking our colleagues who work in the Integrated Care Board and all of our partner organisations. You'll see in their assessment of our performance, which covers notable changes in system performance over the past year, everything from urgent emergency care, ambulance response times, meeting our national commitment to reduce the number of patients waiting more than 62 days for cancer treatment, mental health and dentistry in the report, and none of this would be possible without the colleagues who work within the Integrated Care Board, but also our partner organisations. Notably, within the annual assessment, it does recognise that we've delivered on our financial duties as well as an ICB, but it also highlights areas for ongoing work and improvement, one of those being around learning disability services, and I'm really pleased that we're getting a comprehensive update today from our Chief Delivery Officer on this matter, Chair. My report also touches on the work that we've been doing around equality, diversity and inclusion, and the reason why I'm mentioning this is an ongoing priority for us right across the Integrated Care Board, but also working with our partners in the system. Unfortunately, we did in our region see public disorder, and whilst the cause of that is quite deep-rooted, and indeed we're seeing nationally across the country a period of unrest, I think in the aftermath of that, both talking with NHS leaders but also with our partners in the system, the ongoing work around creating inclusive environments for our workforce, and particularly in the health service, where a significant part of our workforce comes from the global majority, with over 25% of our workforce being from ethnic minorities, ensuring that both we champion inclusive workplaces but also play our role wider within the community in tackling the and rooting out racism and discrimination is a priority for us. And I'm delighted that in the ICB, the early work that we've started to undertake on this has been recognised with a Talent Inclusion and Diversity Award. And also, we are the first integrated care system in England to fully sign up to the inclusive HR approach, which is part of a nationally recognised approach through the Healthcare Professionals Association. And again, want to thank all of our NHS organisations for both recognising the importance of this. What I would say on this is we really are at the start of our work on this, and tackling racism, rooting out all forms of discrimination in our workplaces is particularly key. In the aftermath of those riots, we did also hear our Secretary of State for Healthcare be very clear and unequivocal in his words, which is we will not accept and tolerate racism across our health services. And I think I'm sure board members fully support this, but equally saying these things and putting them into practice is sometimes more challenging to do, and therefore ensuring that we've got the right training, the right advice, and we're building in those inclusive practices into everything we do, right through from recruiting our workforce, but supporting them, particularly when they may be dealing with some of those more challenging situations of experiencing and or seeing racism in the workplace, and what to do on that is why we've signed up to that particular award. And this is something for us as a board. We each need to have objectives around equality, diversity, inclusion, and I'm pleased that we've taken this seriously as an organisation, as a board, and we're very much committed to this. It is vaccination season again, and our vaccination team have been doing a really sterling work. Their work actually goes right throughout the year, and working very closely with our public health colleagues. So we are promoting all of the usual seasonal vaccinations for those individuals that are eligible for that. I'm really delighted that our vaccination team has been able to extend further the places which are delivering the vaccinations, and we've also committed over £500,000 working with our public health partners to get their support in terms of the uptake of the vaccination. What I would say is that it's really important that we're not complacent. I say that with the weather changing around us, we know that the seasonal viral season is upon us, and indeed this can really stretch and put demand on our services, but we also know that the data still tells us that if you've got the vaccination, if you do get flu or COVID, your outcomes can be slightly better, and also less dependency on our hospital services, which, as I said already, can be incredibly stretched over the months and weeks ahead. So really would encourage everybody who's eligible for their vaccination to take that up. And again, thank you to our colleagues in public health who are doing all we can to target and promote the uptake of the vaccination, particularly in our more rural communities and some of our more deprived areas as well. Chair, I'm delighted that we've got a particular topic that we're welcoming a guest speaker on later today on child poverty. We know many published reports now on this across our region. 2 in 3 of our children are living in poverty, and also the impact around both economic inactivity in our region as well. And therefore the work we're also doing around our Pathway Zero project, working with Helpforce and volunteers in order to support people into work, whilst it's one strand of work linked into child poverty, we know that there is no one agency or organisation that's going to be able to tackle these things in isolation. We really do need to work together collectively with our combined authorities, local government partners and community and voluntary sector, but really examining and exploring all ways in which we can do that. But from a health perspective on child poverty, our real focus around the secondary prevention, so whether it's things like reducing the number of children who are having tooth extractions as a result of this, really focusing and getting on with doing the more preventative work that we can do working with our agencies is really key. I won't touch on the Darzi report because we've got a separate item on that, but the final thing I just want to mention is GP collective action. Now, this is covered in some detail in my report. First and foremost, I want to both acknowledge and thank our colleagues working in general practice and primary care. We know that when we look at the data, and if you look at our integrated performance report, they continue to do really amazing and astounding levels of activity in terms of both face-to-face appointments and also the number of people they are seeing, which is increasing with the expansion of roles in primary care. Our Chief Delivery Officer, again, will be doing a presentation today looking at primary care access, some of the achievements, but also some of the challenges. And we do know that our colleagues in general practice have been subject to all of the increasing costs that all other parts of the system are subject to, whether it's utility costs or otherwise. And equally, in terms of safety and looking at their capacity, whilst we may have a very high number of people who expect a face-to-face appointment in general practice, when you simply do the equations on the number of GPs, it's really important, therefore, that we continue our focus around the expansion of roles and using the whole multidisciplinary team. And I think, Chair, and we'll come on to this when we as a board reflect on Darzi, what that's told us and how we make that shift to a more preventative care. We are going to have to, through the development of the new 10-year plan, have a conversation with the public about what people can expect, but also what's realistic in terms of what we can deliver. Whilst the matter of the collective action is a matter for government, working with the trade unions, representing our GPs, we continue to do all we can to support our GPs at this particular time, but I do want to recognise that over the weeks and months ahead, there may well be areas that do start to impact on patients and the public in relation to accessing GP services, given the ongoing collective action that is underway in our general practice primary care services. So, Chair, I would just like to pause. I'd like to ask our Medical Director, Dr Neil O'Brien, just to provide us with an update on paediatric audiology.
Thanks, Sam. So yeah, just briefly, there was some reporting in the press over the weekend. There was a national incident around paediatric audiology. There was some concerns around interpretation of some testing of certain audiology testing for neonates. in Scotland. That then resulted in a national review, and we've been playing into that. So all babies that are born have an initial screening test within hospital. If they did not pass that test, then they're referred on to a more specialist centre for a more in-depth test, and it's that step where there are some concerns around interpretation of the tests, some equipment that's maybe out of date, and the environment in which the tests were done. I met with Yvette Ode, who's was the previous regional NHS England medical director, on Friday to talk about our area. There are 4 units that are of concern. We've set up an incident management group which is meeting on Thursday, and we'll be going through all of those 4 units' action plans. They will all be reviewing as to whether or not there are any potential individuals affected by a failure to pick up hearing loss, and then there'll be a look back exercise for all of those individuals, and we'll also be looking at some rapid improvement to make sure that we've got safe and sustainable services going forward. We can't underestimate the seriousness of this, and we are taking it very, very seriously, and we will act. The impact that it would have on a child's development if we fail to pick up any significant hearing loss on their language and speech development, and therefore their educational attainment, is of utmost importance. So we'll be looking at all of those units that have raised concern. I'll bring a more detailed report back. I've just taken over the leadership of this from the Nursing Directorate over the last couple of weeks, but I'll bring a more in-depth report once we've got that.
Thank you, Neil. Chair, happy to take any questions or comments on the report.
Could I, just on item 4.4, Sam, which is the duties of the statutory duties of the ICB, I asked for this to be put on the agenda, and because having been involved in the early stages of the ICB before the legislation was passed, I saw a lot of material circulating on what shouldn't and what should be in the powers of the ICB, and in the final Act, Health and Care Act 2022, we had a formal list of statutory duties, and they are quite wide-ranging and broad-based, including promoting involvement of each patient in their care, enabling patient choice, and then relating to safety and quality of care, relating to ensuring that proper research is being carried out, relating to innovation. So this annex to Sam's report, which relates to item 4.4 in our report, gives just an overview at the moment in each of those areas, which I think is very, very helpful. But I do think in future meetings we might want to take one of these at a time and look at it in more depth. I think just again to emphasise, it is a statutory duty. It isn't simply a background task that we have to carry out, and whether we at some stage want to develop some metrics to measure progress on each of them. But I think that both it's a challenge, but it's also a very interesting task, because we have 3 million people. We have an opportunity to operate as a system across that population and address some of these things and make sure they're progressed. But I don't know whether you want to say anything about it, Sam, but I just wanted to make sure that everybody realised the importance of it, given that it's an appendix to your report.
Yeah, thank you, Chair. Thank you for drawing colleagues' attentions to this. I mean, I thought it was a very useful exercise to do. So we are still a relatively new organisation, and the Act, obviously, the 22 Act, does set out the very clear statutory responsibilities of integrated care boards. So to sort of two and a half years on, if you like, sort of look back and think about actually how we at the moment are fulfilling those statutory duties, I think has been particularly helpful. I would really welcome the board's review of this, and I wonder whether or not this is going to be something we could have as a subject of a board development session, and a sense of actually, whilst this is our assessment of how we feel we're doing on this at the moment, what the full board's view is on this, and actually whether or not that would alter any of our priorities and areas. I think the for me around the areas kind of looking back, things like it is part of our statutory role to secure continuous improvement in services. That is why we've focused particularly around our improvement and learning system, which is BOOST. We have obviously clearly got the statutory role around reducing healthcare inequalities, and as you said, Chair, promoting the involvement of patients, promoting innovation, which is part of why we strengthened our relationship with Health Innovation North East and North Cumbria, and the duty in respect of research. We're currently reviewing our research strategy. So I think the extent to which these statutory duties, how we discharge them, I think is an area which would be worthy of us as a board just doing a bit of reflection on.
Thank you very much. I do think the point you highlighted last about patients and families, having done quite a bit of work on this with the World Health Organization in the last year, I'm in no doubt, not just in this country, but in healthcare everywhere, that patients and families are the largest unmobilised workforce in healthcare, and I think there's much more that we could do to work with them together to try and address some of these areas of improvement that you've talked about. So, any other points or questions on the Chief Executive's report? If not, we'll move on to the specific item that Sam mentioned, the Darzi report. For those of you who aren't aware of where he fits into the scheme of things, Lord Darzi is a surgeon based at St Mary's Hospital, Paddington, a professor at Imperial College London, and during the Brown government, he was a health minister based in the House of Lords. He did a review at that time, a white paper on the NHS, which majored on quality and safety of care and made the point that quality should be the organising principle of the NHS. So the new government asked him back, he's no longer a minister, of course, but to do a rapid review of the NHS, and he did it very comprehensively and also very rapidly, and you have the report, but Sam's going to introduce it, and then we might have a little time to discuss it. Sam.
Yeah, thank you, Chair. I'm really looking forward to discussion on this with the board. So you've got the report, so I won't kind of go through that in any detail, but I just want to draw out a few sort of key points. So, I mean, obviously we're aware that Lord Darzi was commissioned by the government, and the report is really a kind of an analytical diagnosis of the issues that he found and the insights that he gained through that review. And fundamentally, the government is using this as a sort of setting a baseline for the development of a new 10-year plan for health. And I very purposefully say health and not the NHS, because indeed that's one of the things clearly recognised through Lord Darzi's report, that over the last sort of decade or more we've seen both a deterioration in the nation's health and also the impact of austerity and constrained funding in relation to things like increases in waiting lists. And I think it was quite stark and very clearly articulated and laid out in the report when you looked at that data over time. The report also highlights a 37 billion shortfall in capital funding, and members of the board will recall at our last meeting when we received our own infrastructure strategy highlighting the significant shortfall in capital funding available to ensure that all of our facilities across the North East, North Cumbria are up to date, modern and safe. And we've got about a £500 million shortfall just here in our region. Members of the board be aware that we did indeed submit our own evidence to the Darcy review, and part of the evidence we submitted was informed by the landscape of health inequalities across the North East, North Cumbria, and also the impact that we feel here on things like the allocation of funding. We serve parts of our community are highly deprived and also very rural as well, and there's good evidence that tells us the cost of delivering healthcare in more rural settings is more. So we did indeed submit our own evidence as part of the review. The review also kind of told us that, I suppose, given that picture of constrained finances, also the staff experience and what staff have been reporting both through staff surveys, but also the evidence gathered, coupled with reduced management capacity. So there is a sort of a view that is widely held in part, but not always accurate, that the service is overmanaged and we need fewer managers. Actually, Darcy looked at all of the evidence, the comparisons with international comparisons, and recognised that actually we've got an issue around management capacity, which is hampering our ability to transform. And then probably one of the most, I think, pivotal bits of the report is this the pressure on general practice and primary care, and alongside kind of recognising the impacts of austerity over the last decade, that recognition that with the majority of the funding going into the more acute hospital-based sector, the inability, I guess, to really have a more preventative model and one that's in primary care. So we know the vast majority of people are actually seen in general practice in settings other than hospitals, but the vast majority of money goes into hospitals. And we're going to we've got an item today on mental health and learning disability, and Darcy absolutely recognised that there's a real fundamental problem in the distribution of resources between mental health and physical health. And if you think mental health accounts for far more than 20% of the disease burden, and we know from our own work and our clinical strategy here in the North East, North Cumbria, where depression and anxiety are in the highest of the five most kind of prevalent conditions here in our population, but the spending on mental health accounts for less than 10% of the expenditure. So what does all of this mean? This has been, as I said, setting the baseline for what will be a 10-year plan for health. We know that the Department of Health and Social Care is leading the development of that 10-year plan, and that we are anticipating integrated care boards having a role particularly linked to our statutory duties around involving the public and patients and engaging the public. So we can certainly expect over the months ahead for there to be some quite large engagement with the public on what this new 10-year plan will look like. Just to finish, Chair, maybe to open up for discussion, if we look back at our integrated care strategy that we developed, Better Health and Wellbeing for All, and if you look at that alongside the Darcy report and what may come in a 10-year plan, where the Secretary of State has been very clear they're looking for three big shifts: sickness to prevention, hospital to community, and analogue to digital. It's my early assessment that actually the strategic work we've already done fares pretty well. We cover all of those aspects in it. We also talk about developing a neighbourhood model for health. We can expect that to come again through the 10-year plan. So I think whilst we'll want to probably formally, we will at some point in time need to review our plans. We mustn't go into a sort of a planning hiatus to plan for another plan, because to be frank, we spent our first year as a new organisation doing that, and we've got a lot to do. And even through this period of the 10-year plan, we know we're going to have another challenging winter period. We've still got programmes of work around tackling our waiting lists, improving access. But nonetheless, we will at some point need to take a step back. I think probably the most key area we are going to have to get into is this sort of strategic choices around where we allocate our resources. And I think, again, whilst we're at the very early stages of implementing our own integrated care strategy, how we make that sort of what they call, it's a bit of jargon, but they call it the left shift, moving from sort of sickness to prevention, how we really start to increase our resource allocation to target prevention, I think is going to be both our biggest opportunity and perhaps the biggest shift we need to make as an organisation and as a health and care system. So, Chair, those are my reflections, and very much looking forward to discussion with the board.
Thank you very much. There are points that people would like to raise on this. Graham.
Thanks, Chairman. And just to echo Sam's comments, I think we're in a strong position. Many of the elements of our strategic work have actually been ahead of the Darcy report. I think even in our digital strategy, we talked about the shift left quite a long time ago. And I think by going from where we are today, which is about, we often do the same things better, moving from analogue to digital allows us to go and do better things. Fundamentally, both our digital and physical infrastructure will require investment, as we've already said. But I think that investment can then yield dividends when we start to move care from the traditional, fixing people when they're broken to preventing them becoming broken in the first place. But that's not going to happen overnight, and it is a big system change that we need to enact in order to deliver that. Thank you.
Thank you. John Pearce.
Thank you, Chair. Yeah, absolutely agree, and I think really welcome the ambitions set out in those 3 shifts, and they do definitely align with the strategy and direction of travel. I suppose the real challenge is in the implementation and how we move towards those shifts within a really financially constrained setup, and how do we start to make some of those decisions that are going to implement, particularly that acute to community shift. And the shift towards from sickness to prevention. And I suppose just from a children's services perspective, I think it's really important that shift in terms of alignment, mental health was mentioned, but also that alignment in terms of investing in children and young people and prevention at an earlier stage in the life cycle is going to be really critical. So to prevent that escalation further down. So absolutely welcome this, and it's completely in line with the approach from a local authority children's services perspective and across the local authority landscape. But it's getting into that really tricky, how do we actually make that shift in such a financially constrained landscape and to do that.
Thanks, John. Lisa Taylor.
Thank you. The Darcy report's been received with great interest by the VCSE sector, and through the partnership programme, as a sector, we're looking to provide a collective response to each of the different areas within the report, detailing how we might be able to help move things forward. Would that be of interest to share with the board?
Yes, very pleased to receive that, Lisa. Yeah.
Thank you, Lisa. Claire Riley.
Thank you, Chair. The points made around patient and public involvement are really well made, Chair, and I would reflect on some of our work with Healthwatch in recent months, specifically around women's health and also dentistry. The public and patients are really motivated to get involved in this work, so I think it would be really encouraging to more broadly engage the population on some of the key points detailed within the Darcy report and also reflecting on the 10-year plan.
Neil O'Brien.
Thanks. I'm just going to take the opportunity to draw the comparisons between this item and what we're going to be talking about later in the work of Healthier and Fairer and the Clinical Condition Strategic Plan. Healthier and Fairer work is around prevention. It's around targeting the prevention to those at greatest need and those who experience health inequity and healthcare access inequity. And the clinical condition strategic plan is the vast majority of it is around good primary and secondary prevention for the major health conditions in the area. So it's absolutely aligned to the Darcy report.
Thank you. I just wanted to, two things I wanted to say. One was on prevention, which I'm absolutely fully supportive of, but just with my public health training and background, the term prevention was tended in the past to be used fairly narrowly about preventing disease, and the way that public health was conceptualized was of three components: the promotion of health, the prevention of disease, and the protection of health. And I think they're still worth remembering that a lot of the preventive activities are orientated around the use of technology, blood pressure screening, things like that, all of which are absolutely vital. But a traditional approach would also build in the idea of empowering people to live healthier lives and healthier lifestyles, which is not completely captured in the idea of prevention that's being talked about at the moment. And certainly if you were getting into health inequalities, you would not just look at ways of, for example, helping people to reduce their weight. You would also be looking at the environment which promotes obesity, basically. So it's just worth mentioning that let's forget about the bigger picture health inequalities and population health, which overlaps quite heavily with the preventive activities, but there's something extra there that we need to think about. David Stout.
Yeah, I mean, it's about implementation and in a financially constrained environment nationally. I suppose it's going to take a little while for a 10-year plan to be created. And I suppose the operational planning guidance for next year will come very, very late to help us to actually plan. So I suppose the trick for us is to work on the basis, presumably, that there will be an expectation nationally that we will make some progress along these key strands, and that there isn't a barrel load of money around to resolve all the financial problems. So the trick for us, in the absence of any advice coming down, I suppose, over the next 6 months, is to work out, well, okay, what can we actually do practically on those strands, whilst actually still retaining financial balance as best we can, and then check that out when we actually get the documentation in due course. Is that probably what our strategy is? It could be, yes.
Jacqueline, you want to respond to that?
Thank you, Chair. Thank you, David. Yeah, essentially, to get ahead of the game, we're setting out a different and more comprehensive approach to planning in the year ahead, which we're launching in a couple of weeks' time following taking a paper to our exec committee. To which, I guess, we're looking to put into place a one-year plan for the delivery of our strategy, rather than have our planning round dictated by the timelines and the constraints of the annual planning guidance, which tends to be quite reductive and focus on a fairly small number of metrics. And so that process has been set out in detail, and how we'll engage with all elements of the health system, from primary care through to the provider trusts, and we're launching that in a couple of weeks' time. So recognise the constraints that you describe. I think we do need to think about the degree to which we make some financial allocative decisions within the constraints that do move us, however, incrementally towards the delivery of our strategy, as well as you describe, look at the opportunities to transform existing services and use existing resources differently to meet those ends. And I guess the other thing I would say is that we're very much aligning our planning and delivery mechanisms within the ICB and the integrated care system more widely, so that our transformation programmes, for example, establish a new one around living and ageing well, which is around transforming our community services, so more about community service delivery than prevention specifically, which sits in Healthier and Fairer, which Levi's chairing, and we're looking there about how can we measure the impact of the work that we're doing to deliver that so-called left shift. We're developing a metric that looks at how we support people to stay longer in their own homes, for example, which is a sort of North Star metric under which there'll be a lot of individual programmes. Thanks.
Sam.
Thank you, Chair. I think one of the other areas I think you're absolutely right, and both yourself and John kind of highlight the sort of the economically constrained environment, and the very clear message is there isn't any additional resources. And then on the other hand, you look at the sort of the resources we've got and how we use that to best effect. So one of the big messages, and this is also kind of grounded, we've been working on this for some time in our system to try and secure additional resources, is around how we can sort of have health to support the growth of the economy. And again, working very closely with our local government partners and combined authority, when we look at our hotspots for what would be termed as economically inactive areas, where we've got high levels of economic inactivity in adults of working age, what could be a health response to that, working with our partners to support people into employment. First and foremost, we are the largest employer in the region, so how do we use our own abilities to provide employment opportunities for people, but also working with community and voluntary sector, how do we target and support people who want to get back into work but may, for example, be waiting on a waiting list for a orthopaedic procedure. And we've got a very well tested programme called Waiting Well, which at the moment is targeting interventions for people to promote and support their preparedness for their procedures and their recovery time. How would we look to expand that? So around looking at sort of prosperity of the region and economic growth, where have we got the opportunities here in the North East from an NHS perspective, working with our partners? And that's been a real priority area for us strategically, to think about how we could potentially attract some new investment into the region to support economic growth and prosperity, and to have kind of health play their part in that.
Thank you. Tom Hall.
Thank you very much.
Thank you, Sir Liam. I guess I'm at risk of building on a lot of what other people have already said, but just some of Sam's comments there really resonated with me, and that kind of challenge about how we use the resources we've already got differently is a really knotty conundrum, isn't it? Because we know where we should be paying attention, and we're going to come on to a report around mental health, which I think every time we talk about it at this board, it kind of makes my eyes water at the kind of the need that's there, but yet we're not able to meet that need. But then that in itself has a much wider impact on employability. It then affects the local economy, and that becomes a downward spiral. So there is a real challenge for us to think about how we respond to this report here and now without the details of what comes next. And I'd love us to start thinking about, well, what do we want to hold ourselves to account for in relation to that? How are we going to hold ourselves to account in terms of that left shift? How are we going to hold ourselves to account around mental health investment and trying to respond to some of the need that's already there in the community? And then just linking to your point, Cillian, that's not a sole NHS challenge, is it? The challenges around particularly the inequalities we see in the North East are system challenges. It's how do we go on that journey alongside our local place partners, local authorities, voluntary community sector organisations. Because I was struck recently by some data we were looking at locally in South Tyneside about the premature mortality gap for men between the most affluent and most deprived areas, and that gap is increasing over time in a modern economy. How we continuing to see these early deaths in more deprived males compared to more affluent males, that's not an NHS issue. That's a local system issue that's built on by austerity. So I think this is a really brilliant opportunity for us to re-look at our approach and re-look at what we're holding ourselves accountable for as a board, because I think a lot of it does sit within our gift, as well as what might come down in terms of the detail from the Darzi report.
Thank you, Tom. Thank you very much. Sarah Malik.
Thank you, Chair. Sam, thank you for reflecting on the Darcy report, and it also brought to mind the Women in the Health North report as well, which was quite stark reading. And I guess it's just building upon what you've already said about the finance and what Tom has just said. But we know that 1 in 3 people, 1 in 3 of our patients in the region live in poverty. So is it time then to kind of speak to central government and say that we need to have more funding in order to develop something different? What would we stop doing to do something different, and how would the money shift from hospital to community? It's just a lot of food for thought, isn't it? And I'd appreciate your reflections on that.
Yeah, I think it is. I mean, I think we've been fairly consistent here since, you know, we became an organisation actually in looking at both the health inequalities, the level of the burden of kind of disease, the life expectancy going the wrong way in many, and also the quality of years lived as well going the wrong way, and also the impact that COVID had on this region. You know, there's kind of issues built in systemically over many years, and yet we have a funding formula which certainly works better for growing ageing populations, and we have a static population that isn't growing, which means that we start every year from a health perspective with less money because money is moved to other areas. So I think if we are really serious about this, I think it is going to require a combination of things. There isn't going to be kind of one big thing. It's going to require us to do some things differently. And I think it's also going to require us to have a very strong collective voice across the region, working with those members that represent the communities here to make sure that this region is getting a fair deal for the needs of the population. And I think at the moment we've been very consistent in saying that we do not believe the funding formula works better and works well for us, and we're sort of trapped in this vicious cycle at the moment of health inequalities. And if we are going to truly make that left shift, we will require investment. Now, given the national kind of economy at the moment, you know, we are not going to attract additional money without doing some things differently. And I think that will come with reform of the public sector. It will come with growing the economy, getting more people who are of working age into work, into good opportunities. And I think we need to be prepared to think differently, working with our combined authorities, our local government partners, on how we do that together to use the full collective resource that we've got available here for our region and our communities.
Thank you. Mike Smith.
Thank you, Sam, for introducing this item. I think I would agree that our current strategies align well with what's in the Darcy report, in particular that left shift we've been talking about. In the Finance, Performance and Investment Committee, we've been having conversations already about trying to identify from a finance perspective what proportion of our spend is on prevention. And it's intricately difficult to do, but the finance team are exploring that already, just to demonstrate that we're essentially slightly ahead of the curve, but still getting there. I think also from our performance metrics side, we obviously focus a lot on day-to-day operational measures and things like activity in secondary care, for example, activity in A&E. I think perhaps if we maybe want to demonstrate more of a shift to the left, we need to maybe keep our focus on those preventative measures rather than the activity measures, which are naturally more appealing to look at and they move more regularly.
Thank you. I think we need to thank you for all the points and questions you've raised. That was a very useful discussion. I think we need to move on now in the interests of time. But just to ask you, Sam, do you know what the government's intention is with this report? Is there going to be an implementation document or some other response to it?
I think the response will be predominantly the 10-year plan for health, Salim, which we will have every opportunity to contribute to. And as I said, I think we'll also have a particular role around how our communities are engaged in shaping that.
Thank you. Moving on then to item 10, which is the Constitution, and I'll pass over to Claire Riley to introduce this.
Thank you, Chair. The board will be more than familiar with this document. This has been coming to board since we were formed just over 2 years ago. And we have an updated position in front of you. We've received some further NHSE guidance, which has been reflected within the revised constitution. We've also made some further changes that reflect the independent non-exec director, member changes, and also the partner members of the board. We've also made some final changes linked to David Perdue leaving, given his role, and therefore that has also been reflected within the constitution, which is due to take effect following David leaving. The paper is here for approval of the amendments and approval also to issue to NHS England.
Okay. Do people happy to do that? Dave Galloway.
Yeah, thanks, Chair, and thanks, Claire. I think it's really important, the switch here, so we have a dental representative around the board table, which has been really well received by the dental community, so we're looking forward to getting that insight into the board.
Okay. Is everybody happy to approve the changes and the submission? Thank you. All right, then we move to the item on the reports of the board's committees, and we usually do this by asking the chair of each committee to highlight the main points, and there's a slide for each committee. So we start with the executive committee. Sam Allen.
Thank you, Chair. So the highlight report and the papers include the minutes from the meeting on the 9th and the 13th of July. Just to share with members of the board that we have started to invite representatives from our 6 local delivery teams to share with the executive committee their plans, what's going well, the areas that they're working on, and areas for development. And at our last meeting, we had the Newcastle and Gateshead local delivery team and the Sunderland South Tyneside local delivery team, and each of their presentations were well received, and I think really did highlight the amount of work that our teams are undertaking at a place level, and also the opportunities we've got to share both their expertise and their practice across the ICB. We did also receive a number of papers, and you've got the decision log within the board papers today that sets out all of the key areas. But just to say, the committee accepted the recommendations for the long-term conditions system development funding proposal, and we also received and noted the data, digital and technology strategic plan date. I was also really pleased, and just want to also mention we received and signed off the Provider Collaborative Responsibility Agreement, and that is in its 2nd year now of development. That's an annual plan that we agreed jointly with our provider collaborative, which Ken Bremner is the chair of, and again just want to recognise the work that they have been undertaking, working collaboratively with the ICB, and particularly their areas of success, most notably with the aseptics development proposal. They've secured over £30 million of capital to develop, which will be a really significant asset for the region, and also add in a number of new jobs into the local economy as well. Thank you, Chair.
Thank you. Are there any questions or comments on the executive committee business? Thank you. We'll move on now to the Quality and Safety Committee, and Deputy Chair of this committee, Sarah Malik, is going to report.
Thank you, Chair. Board members will have read the committee members, so I will just highlight a few points from the meeting of always, which is a very full and detailed meeting. We always start with a patient story, one of my favourite parts of the meeting, and this time we were fortunate to have a female member of our Bangladeshi community speaking to us about their worries, concerns and experiences when trying to access healthcare services. We had quite an in-depth discussion about what could be done and who to speak to work upon this further, but also to understand how we could digitally and technologically move forward without causing any detrimental harm or leaving anybody behind in this process. We had exceptional reporting, including never events, healthcare associated infections, maternal deaths, learning disability concerns, all age continuing care and safeguarding. And we also had an in-depth discussion concerning the GP collective action, not just about prescribing and access to medications on a short and long-term impact, but really about patients accessing safe and quality-led care. We also had annual reports received from Safeguarding, Medicines Optimisation and our leader reports as well. Thank you, Chair.
Thank you. Any comments or questions on this committee's business? Graham Evans.
Thanks, Chairman. Just to comment on the digital exclusion point, so we have got quite a robust and mature digital inclusion group. We had a conversation about 2 weeks ago in Gateshead Council to develop and get some co-production in the development of that strategy. So we will make sure that we cover all of the parts that you've mentioned. Thank you.
Okay, thank you very much. And now then to the Finance, Performance and Investment Committee, and Mike Smith, Deputy Chair, is going to present this.
Thank you, Chair. So there's in the data pack, there's 2 meetings worth of information, but I'll only be talking about the more recent September meeting, as John spoke about the July meeting in our last board meeting. We've now aligned the sessions to match the board meetings. In the September meeting, we received a detailed presentation on the Dental Access Recovery Plan, and we're assured that there is a lot of good work going on in that direction, and felt that the direction was positive, albeit a long way to go. We also received the Mental Health, Learning Disabilities and Neurodiversity presentation, which we're about to receive as a board, so I won't spoil any surprises on that one. We received some information about the oversight arrangements for the independent sector, and we're able to scrutinise that in a good degree of detail. With regard to the finance, we received an update. There's been some slight updates to it since we received it at the FPI meeting. So I won't go into great detail on that, but we were assured that there is a cost improvement programme ongoing for non-clinical staff led by the Provider Collaborative, and Audit One are also working on cost controls as well. From a performance perspective, the main highlight point that we observed was that there was the intention to eradicate the 65-week wait by September was looking challenging at that point due to a lot of often quite small-scale local measures, but there was a lot of work going on to try and get as close as possible to that. As I've already alluded to, from a healthier and fairer perspective, looking to bring a report to board twice a year and looking into detail on how the finances align to prevention and the left shift. And ongoing work, working with various providers to address performance challenges.
Thank you very much, Mike. Any points anyone wants to raise on that? Okay, thank you. We move on now to item 12, the Integrated Delivery Report, and Jacqueline Myers is going to present that.
Thank you, Salim. So in this board meeting, I thought I would try something slightly different to set us up nicely for the discussions later in the board. So you have, as usual, the comprehensive integrated delivery report and supporting appendices. And of course, as ever, happy to take any questions in relation to the report. But for the presentation, I thought I'd bring you some slightly wider information. So firstly, I'm going to talk you through this slide of performance highlights. So this is a new exposition of the key highlights in terms of performance. And this is slightly more up to date. It's 1 month more up to date than the information contained with the IDR. So it's an opportunity to bring the board up to date outside of the formal assurance process in terms of how things lie on the key metrics. So I'll just talk you through some of the data that's shared here. So starting on the left, as is traditional, and looking at the urgent and emergency care performance, and these are August data for urgent and emergency care. I would like to first of all highlight the performance of our North East Ambulance Service, who are having a very good year in terms of their response times. They have, across the year to date, up to and including August, both exceeded for the Category 2 response times. Those are the not the life and limb, but the second most urgent, things like heart attacks and strokes. They've both exceeded the national ask for this year, which is 30 minutes, and they've exceeded their own plan. So very impressive performance. And in terms of those Category 1 response times, so those life and limb ones, they have delivered the national ask and performed best of all 11 ambulance services in England. So really pleasing to see there. Moving down and looking at the August A&E 4-hour target performance across the ICB, we achieved 80% of our patients being either treated and admitted or seen and treated and discharged. So that's 4 out of 5 patients in August who attended our A&E departments being met within the national standard. Obviously still a long way from where we'd like to get to in relation to that target, but it's worth noting it's our best performance to date in a month since we existed as an ICB. I've just lost my screen, so I'll have to re-log on. Perfect timing. Just to say that we didn't actually meet our own planned target in August. We were slightly short of it. We were looking to deliver 80.6, but nonetheless a pretty good performance. And you can see there that we were the 4th best ICB in England in relation to 4 hours in August. Slightly more concerning is the situation in relation to the metric that measures what you might colloquially call delayed discharges. So the percentage of patients in our acute beds, in our acute hospitals, who are defined as having no clinical criteria to reside, that is higher than our plan at 9.7, and of concern given August traditionally is a month where we see a lower number of patients in that scenario, so one to watch as we move into winter, and in response to that a renewed focus on all of the work we're doing both to prevent admissions and then facilitate rapid discharges once patients are ready to leave the acute setting is being renewed. Looking at our cancer performance, won't dwell on this too much, but just to say we've continued across the summer, and now we move into July data for the rest of this scorecard to see a slow but steady improvement both in the size of the backlog, so patients who've already waited longer than 62 days for either diagnosis or if they do have cancer for their definitive treatment to start, and for the percentage of patients on that pathway that get their treatment or diagnosis within 62 days, and also for faster diagnosis we continue to deliver the standard, and that's pretty good across the board, so nice to see that. Down the middle of the scorecard we have our planned elective care metrics. Again, these are July data. Bit of a mixed picture here. We are still seeing the overall waiting list across the region grow slowly but steadily. It did flatline for about 6 months during the winter, but since the spring it's been growing again, so that's really of concern in terms of sustainability as we look to get ourselves in a position where we can deliver reasonable waiting times. But it's worth looking at the bottom there and seeing that in terms of that measure that used to be used nationally around referral to treatment target for planned care, the 18-week target, we are the best in the country. So 69% of patients are being having their referral to treatment pathway completed within 18 weeks. So in terms of the shape of the waiting list, nice to know that we've got 70% of patients, or 69% of patients being treated in target. In the middle of the scorecard, you've got the progress there in terms of the very longest waits. And you can see that while waits are falling, we are behind our own plan. And the board will recall that there's a national ask that we eliminate over 65-week waits by the end of the month that just finished yesterday. We're waiting for the final data to be validated, but it's clear that we won't fully eliminate those waits by the end of September, unfortunately. We have made really significant progress. We'll have around 350 patients still waiting over 65 weeks across 3 of our provider trusts. So we're working with them very intensively to work through the revised trajectory, i.e. timeline, to get the rest of those patients and the new patients that are now waiting over 65 weeks treated so that we can hold that maximum waiting time below 65 weeks. I'm going to go to the bottom of the scorecard now and just look at the primary care, both GP and dental metrics, and you can see there that the number of appointments per month is holding up well in general practice and is larger than our plan, and that the numbers of patients who are seen with next day or within 2 weeks is also holding up okay. We're still in development on our dental metrics, it's fair to say, but what we're measuring here and we're waiting for national validated data to flow. So here we're measuring some of our local information. We're measuring whether or not we're meeting our own activity plan. And although the arrow suggests, it doesn't suggest, indicates that we did a slightly smaller amount of activity in the previous month, we are exceeding our plan. And if you can see the very small print there, you can see that compared to the national benchmark, we're actually doing pretty well. And that reflects the local additional recovery plans and activity plans that we've put in place through our local contract arrangements. So hopefully that's a useful canter through. The last part of the performance card is around mental health, and you'll see a bit of a mixed picture there. The talking therapies, reliable recovery and reliable improvement, slightly worse than the previous month, but and slightly below the national target. And that's a new measure that appears for the first time in the integrated delivery report and therefore on the scorecard. That is the single measure that we're being held to account to nationally in relation to talking therapies for anxiety and depression. I'm going to take the opportunity to kind of get underneath those metrics and have a look at what's going on in terms of anxiety and depression in our region shortly in the second part of my presentation. You can see in terms of the two measures we have in the middle there, we're measuring the activity volumes in both our children and young people and our adult mental health services. We are, in terms of children, exceeding our plan, although the number has dropped slightly compared to the previous month. And we don't have a national target for our adult service, but we are seeing increasing numbers of people being seen. What I want to say about this is that since we last met as a board, we have finally now received a national data set for mental health waiting times that we'll be working with our provider trust to implement over the coming months. It will be a huge task to get that implemented. Those of us who were part of implementing standard waiting times data sets in the acute sector over the last 20 years know what a significant piece of work that can be, but we very much welcome that standard data set. And I think it will be helpful for us to have a better understanding of waiting times. So if I may now, Chair, what I'm going to do is do a little bit of a deep dive in terms of more information behind two of the headline metrics. So first of all, I'm going to take a look at anxiety and depression, and we've pulled together a selection of slides that try and paint a bit of a picture in terms of the prevalence and the treatments and responses to see if that points up some opportunities for a different way of doing things, which hopefully sets us up nicely for the very comprehensive transformation plan that my colleague Levi is going to present later this afternoon. So what we're looking at here is GP practice registers for depression as a marker for prevalence. There are some cautions to put on these data in that GP colleagues tell me that perhaps we are better at putting people onto registers than we are at taking them off, so there could be a degree to which these registers pick up more prevalence over time. However, I suppose we should also recognise that depression is often a long-term condition, and you know, the opportunity to consider someone completely, if you like, cured and free of depression is not the most regular occurrence. But what these data tell us is that 3 in 20 of adults in our population in North East and North Cumbria are on a register and so recognised as suffering from depression. And the bar chart in the bottom corner there is comparing the growth in the number of people on these registers. The blue bars are North East and North Cumbria and the orange are England. So what those data are telling you is that prevalence is growing as defined by these registers, notwithstanding the caveat I've just shared, and it's growing faster in our region than it is in England. So we have a faster rate, and so that's significant because we're all using the same registers across England, and we're seeing more people being added to registers than we are in the rest of the England population. And in the corner there you can see that we've added 67,000 people to these registers across this 4-year period. So this next slide looks at prescribing of selective serotonin reuptake inhibitors, SSRIs. Colloquially, we might describe those as antidepressant medications. And again, what this shows you, and this is another, perhaps, has been suggested, a more accurate marker of prevalence, that we have much higher rates of prescribing of these medication than the rest of England, and we have growing rates too, so of concern. The board will know that talking therapies are recognised as an effective treatment either in isolation or in combination with medication. And the next slide looks at how the degree to which we are using talking therapies as a treatment for this population. And what this is telling you is that referral rates as a percentage of the people who are registered are falling and access is falling. Now, this doesn't mean we're doing less talking therapy activity in absolute terms, because as you've seen, prevalence is growing, but it does mean that a smaller proportion of the population who are recognised as having anxiety and depression are accessing talking therapies in our region over the last few years. So that would suggest that we haven't managed to grow that service to match the growing prevalence that we're identifying. I thought it was helpful just to share some feedback. You may not be able to see this, and I don't propose to read it all out, but I will share the slides with the board later, and for those who are watching online, they'll be able to see this much closer. But this is just a sample of patient feedback for 3 of our patients who have recently accessed the talking therapist service that's provided in our Sunderland place. And if you get a chance to read these, you'll see that they are just overwhelmingly positive. In fact, life-changing is how 2 out of 3 of these patients describe the service that they received. So it's just a sample, but there's lots more where this comes from, and I think it's just helpful to highlight that. So I guess all of that taken together suggests that, anxiety and depression is a really significant and growing challenge for our population, that we are identifying patients and they are accessing medication, and to agree they are accessing talking therapies, but there clearly is a suggested opportunity to expand our talking therapies service and make it available to a larger number of those patients. And the metrics that we have within our IDR, which are nationally fine so far, I don't feel adequately kind of reflect this picture, so it's helpful to dig underneath. We'll have a close look at the new data set that's been published and see whether that gives us a better view, and we can continue to give the board a sort of clearer picture of what's going on for this patient population. Lastly, Chair, I just wanted to have a quick look at what's going on with ADHD and autism referrals. So this is a subset of the patients who are within our community mental health services who are waiting to be seen. So they're in the outpatient waiting list. And again, this is context setting, but I'm not sure that this comes out as clearly as it might in the metrics that we currently use, because we don't pull these pathways out of our overall waiting time. And indeed, prior to the new data set, we just measured the proportion of the waiting list that was over 3 months. That was the national measure, so I thought this was useful. Firstly, in terms of demand, what you can see here is that between 1920 and the year to date, we've seen a 4-fold growth in the number of children and young people who are referred into this pathway, and a 7-fold growth in the number of adults who are referred into the pathway. So really, really significant growth, which obviously presents a massive challenge. This is not unique to the North East and North Cumbria. This is reflective of the position nationally. And across that same time period, I just wanted to show you, to the best of our knowledge, what the position is in terms of the number of people who are so the proportion of that of the waiting list who are waiting over a year to be seen. And you can see from a position in March 2020 where essentially over 1 year waits were not an issue. They were not part of the feature of the service, that we've seen this steady growth. So you can see that as at March 24, there we had over 12,000 adults and over 7,000 children waiting over a year to be seen, and that represents half of the adult waiting list and nearly half of the children's waiting list. And it's worth noting that our longest waits in this pathway are over 4 years. So that just concludes the areas that I wanted to highlight. Happy as ever to take any questions. Thank you.
Thank you very much, Jacqueline. And I think it's obvious that a lot of work's been done by you and your team to improve the accessibility of the complex data that we have to look at, and it shows in that presentation, so thank you very much. Comments and questions then? Yes, go ahead, please.
Thank you for the presentation, Jacqueline. Can I just ask on the particular item of elective, and I know it's out of the 42 ICBs with top performing, but is there any data to show how long people are waiting before they get on the waiting list? bearing in mind that access to GP appointments within 2 weeks is worsening, and some of the data we receive and within Healthwatch is it's taking such a long time in order to get that initial referral in order to go on a waiting list.
I think the short answer is no, I don't have those data to hand. Just to remind the board, it's not a measure of people being added to waiting list, but it's a measure from referral to treatment. So it does capture the point at which the referral is sent, rather than the point at which patients are part way down the pathway and get added to waiting list. But the degree to which there might be delays in those referrals being submitted from the GPs or other referrers to the receiving provider, we don't have a single measure for that. There are things, proxy measures we could dig into and look at. So I could take that away.
Can I just come back? It wasn't really a delay from the GP. It just seems to be a bit of a postcode lottery for people accessing, like, you know, that initial assessment, MRI scans, things like that, before they end up being on a waiting list.
Yeah.
Sorry, so just to confirm, when we look at the referral to treatment waiting times, they incorporate that whole pathway. Thanks.
Thank you. We sort of related to Christopher's question, is that obviously we don't have ongoing data on the prevalence of a lot of conditions, so all of the data we do use are proxies of one sort or another. In the case of depression, it's people who've seen their GP and been formally diagnosed. So I just wondered, it's difficult because when we're looking at the size of the burden of disease we've got out there, then it would be interesting to know whether the real figure is twice as much, 5 times as much, 10 times as much. I guess there's methodological work that could be done to do some surveys to show how much of a correction needs to be made on the basis of only using that sort of data. But otherwise, you're into long-term research studies that take a long time to produce any results.
Yeah, others may want to comment, but for some of the markers for secondary prevention, for example, atrial fibrillation, there are databases that give us an estimated prevalence and will show the gap between the number of patients that we have on GP registers and the numbers that would be expected to be on GP registers. So we do have some recourse to some wider data sets that would give us a sense of the degree to which we have identified the disease burden. We could certainly have a look at that and do a sort of deeper dive into that if that would be helpful for the board.
I mean, just before Sam comes in, some of the national surveys, of course, are available, but only some of them can be disaggregated to our level, because then you get into small population sizes, because they're all based on sample surveys, mainly the Health Survey for England being an example. Sam, you want to come in?
Just wanted to come respond quickly to Christopher's point as well, which I was kind of picking up as the sort of variation in performance, because sometimes when we look at data, we're looking at aggregated data here across the whole of the North East, North Cumbria, but actually there will be differences when you get down into whether it's Hartlepool or Sunderland or Newcastle, both in terms of the kind of population profile, so the prevalence of depression or the prescribing of antidepressants, but also around some variation, some of it warranted and expected, but some of it unwarranted, around whether it's the 4-hour waits in the emergency department. I wonder, Jacqueline, whether you wanted to say a bit about what we're doing around looking at the data in that way, so that we make sure we're not missing any hotspots, I think as you described them, Christopher, that we should pick up that are sort of more of a postcode lottery on access.
Yeah, happy to. Thanks, Sam. So, I mean, whilst it's difficult within the sort of time confines of the board meeting to get into that granular depth of the variation underneath the whole ICB position, that's certainly something that we routinely do. So we look at For example, referral to treatment waiting times by provider. We look at it by specialty. We identify areas where we've got concerns. We put a range of remedial actions in place, both in terms of talking bilaterally to individual providers and then working with the provider collaborative and its strategic elective recovery programme to initiate work to make improvements across multiple places where perhaps we have a concern about a particular specialty. Also, we do periodically, regularly look at some other cuts of those data. So, for example, we look at it in relation to the multiple, the indicators of multiple deprivation and also ethnicity, so that we identify whether there are differences in waiting times or referral rates by certain population indicators, so that, again, if we identify that there are areas of concern, we can look into that and look to see if we can remediate it. And then Sam's also already mentioned our Waiting Well programme, which particularly focuses on supporting people from more deprived communities who are waiting for a long time on the waiting list because they're waiting for more routine procedures. Thanks.
Thank you. Mike Smith.
Thank you, Jacqueline, for the updated report. I would echo the Chair's compliments that the new format was really accessible and helpful. And I wonder whether next time for the deep dive section, which again I found insightful today, would be whether we could have something on prevention on the left shift and perhaps focus on the prevention performance.
Certainly.
Yes.
Okay, thank you. Move on then to the next item, which is the regular finance report that the board receives. And Phil Argent, deputising for David Chandler, is going to give that.
Thank you, Chair. So I'm here today to present the financial performance for the ICB and the ICS for the first 4 months of the year up to the end of 31st of July. I will assume the board members have seen the paper in the pack, so I'm going to talk through this in the context of the statutory financial duties of the ICB to take you through it step by step. So firstly, the first financial duty is around the ICB needing to achieve our planned surplus of 53.6 million for this financial year. It is early in the year in terms of data. Obviously, there's a 2-month time lag with much of the data that we would use to put together the financial forecasts, things like the GP prescribing data, for example. But at this stage, we are forecasting to achieve that £53.6 million surplus in line with plan. Year to date, we have an £18.2 million surplus reported, which is slightly ahead of plan, about 360k ahead of our planned position at this stage. And therefore, we are confident that we will continue to deliver that forecast in line with plan by the end of the year. Within that position, we have seen some pressure on the GP prescribing costs in these first 4 months of the year, largely due to some price concessions in the early months of this year, which is offset slightly through slight underspends against packages of care and community services budgets. And all of this underlines the importance of achieving our overall efficiency plan for the year, which for the ICB is largely focused around packages of care and GP prescribing costs. The second financial duty relates to the overall position of the ICS and the achievement of the overall deficit plan of £50 million for this financial year. Currently, there is a small adverse variance reported year to date against that plan, about 1.7 million, which reflects largely drugs costs for NICE approvals on drugs and devices, some escalation beds, which in one particular trust had remained open longer than planned, under delivery of efficiency plans year to date, and also, of course, industrial action experienced in the early months of this year. This is an improvement on the month 3 position, however, which did have an adverse year-to-date variance of about 3.8 million, and the overall position is expected to be managed back in line with plan by the end of the year to achieve the £50 million deficit. Part of the offset against those pressures that we've experienced in year is around the elective recovery funding income. We are forecasting as a system to be well ahead of the national target set for elective recovery, and therefore we are looking good in terms of the income the system can expect to receive for elective recovery. I should also add that as we had an agreed deficit plan of 50 million for the financial year, Nationally, deficit support funding is being released, so an additional £50 million allocation will be coming to the system. So from month 6 reporting onwards, you will expect to see us reporting a break-even forecast position for the ICS. Whilst I'm talking about the overall ICS position, I will just touch on the run rate. You may notice that the year-to-date deficit of £38.7 million versus a full-year deficit of £50 million looks like a larger than expected deficit at this stage of the year. Just to be clear that was a planned for trend. It's fully as expected, with only that small adverse variance against plan at this stage. And that's largely down to the profile of delivering efficiency plans throughout the year, with a greater emphasis on delivery in the back half of the year. But it does mean that we will be making sure to keep a close eye on delivery of those efficiency plans as we go through the year, with such a large weighting of that in the back half of the year. So to touch on efficiency plans as a whole, we are slightly behind plan on efficiency, about 2.9 million year to date. And also I should say, slightly behind plan on recurrent delivery of efficiency, which is largely offset with non-recurrent delivery in this early part of the year. But again, very important that those challenging delivery plans are delivered across both the ICB and the ICS as we go through the remainder of the financial year. Just to touch on risk, the overall plan included about 160 million of unmitigated net risk. Reported at month 4, that is now down to about 98 million, so an improvement in the unmitigated net risk. But going forward, there will be some additional measures in place from month 5 report, and looking at run rate and risk and mitigation through the rest of the year, just to add that extra layer of assurance that those risks are being managed and monitored as we go throughout the financial year. So to move on to the third statutory financial duty is around capital and remaining within our capital allocation. The current forecast for capital is in line with plan, which appears like an overperformance against our national capital departmental expenditure limit. However, plans do allow for a 5% over-programming, given the volatility of starting points of capital schemes, and therefore that's why that looks like a forecast which is around 9 million in excess of our overall allocation, but that will be managed down to within our overall CDAL limit throughout the remainder of the financial year. Final of our statutory financial duties that I was going to touch on today was around running costs. Currently, the ICB is forecasting an underspend of around 2.9 million against our running cost budgets, partly due to vacancies, but that is an expected underperformance as the full reduction in running costs allowance isn't coming into force until 25-26. So having been through the process of ICB2, that is an expected underspend at this stage, which is helping to offset some of the pressures in programme budgets as well in the financial position this year. There is a new slide in the pack this month around workforce, which you will notice showing a 0.4% increase in workforce when using the 12-month average data. However, within that, there is bank and agency workforce levels down 8.5%, which is obviously a huge move in the right direction in terms of the plans for workforce. And those numbers will continue to be reviewed both in the ICS workforce group and, of course, also the System Recovery Board as we go throughout this financial year. I'm just going to touch on the medium-term financial plan as well, if I may. So you will recall that a submission was undertaken in summer last year around the medium-term financial plan. We are expected to refresh and update that this year, and a draft submission is going to NHS England around that this week. That is largely an extension of the model that we put together for 23-24, with a bit more detail to be able to build up a provider-level position for the medium-term financial plan. Clearly, we don't have any national planning guidance yet, but there are a set number of assumptions that we are making as a region across North Eastern Yorkshire with our other 3 partner ICBs as to what we can expect going into future years. That report will be brought both through the Finance Performance Investment Committee and through all of the boards of all of the organisations involved in that plan throughout October. So there will be a further update on the detail therein at a future board meeting. And then the final point I looked to bring today was around the financial grip and control review that we are undertaking as a system. The delivery of the finance plan nationally this year is very challenging, and a number of systems at high risk of overspend had agreed with NHS England to utilise some external support to really dig into the detail and review their financial position of their system. Now, we in North East and North Cumbria are not one of those systems who requires that national scrutiny. However, we felt that despite that, and given the collective financial challenge and risk to all parties in the system, we were proposing to undertake a similar independent review that other systems have been mandated to do. And this, it really dovetails with some of the work that we'd already picked up around grip and control measures that have been discussed through chairs and chief execs meetings. So to that end, a steering group has been established and the work is underway, predominantly through the use of internal audit, through Audit 1, looking to review all of the grip and control measures, which includes effectiveness of those controls, but it looks at everything from workforce, from your non-pay expenditure, and also governance arrangements to really assure that all of the proper processes and oversight are in place in terms of delivering those financial plans. Where Audit 1 do not have the relevant skills and experience, an external provider has also been appointed to pick up those elements of the review. We expect that this work will develop a clear set of recommendations and actions, both at individual organisational level and at system level, just to make sure we can support both delivery of the current year plan, but also that medium-term financial plan going forward into future years. Thank you.
Thank you very much, Phil. David Stout, you're the Chair of the Audit Committee, would like to comment.
Phil, thank you very much. Very clear. I think I understood that. That's good. And it's a good news story so far, month 4, my interpretation. But plenty of risk throughout the rest of the year, backloaded CIPs, etc., etc. So that's a good news part. But even if we deliver in this current year, I suppose what stands out on your backup figures there is the split between recurrent and non-recurrent efficiency savings. Whereas 520 million in total, of which 240 million, something less than a half, is non-recurrent. And I know that wasn't the original desire, because the desire was not to have that level, but this came into the interaction with NHSE about actually living within the 50 million forecast deficit. However, in 6 months' time, I mean, obviously a lot of the focus has been on delivering in the current year, but in 6 months' time, it'll be next year. And in 6 months' time, we'll have a 240 million defined, plus whatever the task is for next year, plus maybe 50 million if they actually want us to break even. So it's all bad news at that stage. So I don't expect any answer to that question. My point really is that in addition to the current year, and that's really important to deliver in the current year, for the next 6 months, we really need to do everything we possibly can to land in the very best position we possibly can for the 1st of April. And that's particularly relevant now because the debate we had around Darcy. We don't particularly want to be distracted by a really difficult financial position, unless we have to be, while we actually would prefer to spend the time around Darcy. So it's really the 6 months now. How do we use that wisely and productively? And I say we mean the whole of the region. And I know it ain't easy. It's never been easy. But what is it we do for the next 6 months to land in the best possible position?
Phil?
Yep, absolutely. When you look at the delivery of recurrent versus non-recurrent, any slippage in the recurrent delivery does cause a financial impact into future financial years. I think some of the grip and control work that I've just described will really allow us to ensure that all organisations within the system are looking over everything they possibly can to convert as much of that non-recurrent efficiency into recurrent to avoid it being a further financial pressure on next year. So some of the recommendations that come out of that work, I think, will be key. Also, the current position around efficiency delivery will be fed into that medium-term financial plan work as well. Yeah. So the longer-term picture is being adjusted based on actual achievement and actual assumptions within the data that we have now. And that medium-term financial plan is intended to be the starting point for our 25-26 operational plan as well. We do expect the planning guidance to be earlier this year, but any head start we can get on that through that medium-term financial plan, I think will put us in good stead to try and mitigate some of the risks that you've described there.
Thank you very much. Ken Bremner.
Just on that last point, if I may, I mean, that's a really good answer, Phil, to that question. And I find this is a dilemma we keep getting dragged back into. We keep getting dragged back into solving the problem in 6 months' time, rather than what I think we're trying to do as a system is to focus on our medium-term sustainability and viability of all our organisations. If we keep getting dragged back into the here and now, we never tackle the medium-term issues. So I think we've got to be hopeful the 10-year plan coming, we'll get a chance to do that. I also hope coming out of Darcy we'll get something akin to multi-year settlements as well, which will allow us to plan a better balance between recurring and non-recurring savings in itself. So I'm much more hopeful that we've got the right start with our medium-term financial plan, and we should really reinforce our focus on that with national bodies and not get distracted too much by the kind of initial bit that's hitting us on the 1st of April next year, notwithstanding David's very valid points about the balance between recurrent and non-recurrent savings. Can I ask Phil two questions as well, if I may, Chair, on the financial report? Can I just be clear that we are doing everything we can to make sure that national bodies understand the degree of reliance we've got on ERF? We do not want any surprises coming in the run up to Christmas or into the new year, where suddenly assumptions we're making about overperformance, which we will have delivered by that stage, is not going to be financed, because we are very reliant across the system on that funding. Now, I know you'll be doing everything, but it's just absolutely making sure we get no surprises from that. The second question is, have you got any whispers about any funding for a couple of issues? One is industrial action, and secondly, clearly winter.
Go ahead, Phil, and Sam might want to add something.
Yeah. Okay, so from the point of view of the Elective Recovery Fund, absolutely, it is clear in all of our monthly reporting, through some of the integrated finance reporting through to NHS England, we put in a forecast every month of what additional income the system is expecting for the financial year for ERF. So nationally, they are very cited on the assumptions made in the financial positions that we put in each month. And we are also linking in with our regional colleagues in NHS England to keep them updated on the position for ERF as well. All of the messages we've been hearing down the line are that the guidance still stands and that ERF will continue to be transacted for this financial year. So I'm not expecting any surprises, as you say, as we come up to winter. But yes, I think we are being as clear as we can be with the national team around our expectations there. In terms of other funding that you'd noted there for industrial action, there has been an announcement of a small amount of funding to cover off the industrial action that occurred earlier in the year. There is no move to adjust things like the ERF targets like there was last year. This would only be a small amount of funding for foundation trusts to cover off the cost of industrial action. But yes, there has been an announcement around that. In terms of winter funding, there has been no announcement around any additional funding for winter at this stage.
Sam?
Yeah, I think just to support that, I think the message has been pretty consistent and clear that the plan this year is the plan and not to expect any further available resources. I think, having said that, we're always hopeful and optimistic, Ken, that may change, and we remain hopeful, but I'm less optimistic given the national position. And as Phil said, our plan is our plan that we've signed off. Our plan is predicated on additional activity being funded through the Elective Recovery Fund, and we'll use every opportunity to keep impressing that. I think there could be a risk nationally, and I think this is what you're alluding to, where if we see significant deterioration in financial performance in other parts of the country, then there will again be choices that need to be made nationally. I'm not aware that those discussions are underway, and therefore we stick to our plan that we've signed off with NHS England here in the North East, North Cumbria. I think we should note the risk in our risk register, given that there is some likelihood at some point in time, if the national picture continues to deteriorate, some choices may well need to be made, but we're not hearing anything on that at the moment.
Thank you. Rajesh Nadkarni.
Thanks, Phil. It's really helpful to see that section on workforce within the report. And as I've noted that there's been an increase in spend, even though we've done something really good with agency and bank. It would be useful, you might have the answer now or not, whether there's any correlation between those two areas, the substantive increase and the agency and bank reduction or not. And more importantly, this probably has to link in with what our people's strategy will be about how we move forward with the Darzi review. It might be that we might have a little bit of more oversight on this area through the Finance Performance Committee as things develop and as we get some more clarity on this particular area. But thanks.
Yeah, absolutely. It's not something I can comment today, but I think this report we can build on and develop and bring more of the detail to the Finance Performance Committee going forward.
David Perdue.
So I can answer some of that question in terms of workforce. So there is some correlation between areas that have increased their substantive establishment, have seen that reduction in agency spend. I think kind of we've got a piece of work for the here and now. And then obviously we have the first year in terms of the long-term workforce plan, which is being refreshed as part of the Darzi review. But we will start that work from April next year in terms of looking at where we need to grow the workforce.
Okay, thank you very much.
So the question I was going to add was just in terms of assurances. I think it's really important that in terms of quality and safety, that we've refreshed and renewed our policy in terms of quality impact assessments and equality impact assessment. And there's a really straightforward standard operating procedure, that process that people go through to ensure that any CIP or any investment looks at the impact of equality and quality. So I just think in terms for the assurance that needs to go on the report, because it's really important that quality maintains and safety remain paramount to our work.
Okay, thank you. I think that's all the comments and questions, but thank you very much, Phil, for the report, and obviously something where progress is going to be very tightly tracked, and we'll get further updates in due course. Item 14 is Primary Care Access Recovery Programme System Plan Update, and Levi Buckley, Chief Delivery Officer, is going to give that report.
Thank you, Chair. As people will remember, this is a regular update that comes to the board. Provide the board hopefully with updates on progress in improving access to primary care and local delivery of the National Recovery Programme. I would note that there is a huge amount of work behind this report, particularly with the primary care transformation team, our local delivery teams, and notably colleagues in general practice. Chair, there's an awful lot of information in the report, so my intent is to highlight some of the key metrics and then happily take any questions of any of the further detail. So people will be familiar with the overview of the Primary Care Recovery Plan. I'm really going to focus on the 4 key areas in the blue boxes towards the bottom: the empowering patients, modern general practice, building capacity and bureaucracy, and hopefully touch on some of the national aims here around addressing the so-called 8 AM rush, and also how patients know on the day that they get in contact with services how their need will be managed. So firstly, in terms of empowering patients, this is really about making sure there are informed decisions about treatment and care that's right for people at the time. And just a couple of metrics to note. The graph on the top right shows the growth in the use of digital tools to support patients managing their own health, and this is primarily through the NHS app. So we are performing well within the region and nationally, and I think just picking up Graham's points earlier in the agenda, we also have a very good focus on digital inclusion and exclusion, so being very aware this is not the right route for everybody, but some good improved performance there. On the bottom left, you can see that we are exceeding the national targets for self-referrals. So that's a good position to be in, but not quite where we want to be. So we continue to look at how we can improve that one for the remaining 2 quarters of the year. In respect of empowering patients, we've heard through the board before about the great work on Pharmacy First. We now have 99% of pharmacists registered, and we continue to, well, we were number 1. We've had a little bit of a taken over by West Yorkshire, so the pharmacy team are determined that we will recoup our number 1 position, but nevertheless, what you can see here is that 72,000 more people have been referred than in November 23 to access these services. So we're really seeing a very helpful alternative route for a number of conditions than to primary care. And indeed, we presented this at the North East Yorkshire Regional Primary Care and Community event last week. Well received nationally, and a number of interested areas want to come and see our progress. The next slide takes you into some areas that are modern general practice. The majority of this is funded outside of the core contract. And just pick up a couple of key points here. So this is a real focus on our better digital telephony, making online processes much clearer so that patients can book consultations, appointments, receive advice and guidance, or indeed sometimes be directed to the practice website. And also a focus on faster care navigation. So are patients directed to the most appropriate member of the general practice team, picking up our chief's comment earlier that we have to make sure we use all members of the multidisciplinary team to direct the best professional to meet the need, the presenting need. And again, we can see in the data here when we compare March of this year back to November 23, we've on a rolling 12-month period, we've had 200,000 more appointments, and we've increased our same-day appointments. So still more to do, but it's definitely going in the right direction. The bottom box on this slide, just to pick a couple of points, just notes the transformation improvement support offer with practices, and sorry, I jumped ahead, and with primary care networks. So we continue to work at a practice level, a PCN level, a local delivery team level, and indeed a regional North East North Cumbria level in respect of the different elements of the General Practice Improvement Programme, supporting funding for modern general practice, and issues such as capacity and access and the payment criteria. There's a lot of technical work that happens behind this to ensure that we can be meeting the aims of the plan. In terms of building capacity, again, our Chief Digital Officer referenced last month, we'd had the work on our infrastructure strategy, and this continues to be an area where workforce and estates come together in terms of how we can increase the capacity. So our workforce has increased through the additional roles reimbursement scheme. And we just in the last week received some further information from NHS England around confirming in the contracts the funding flows to increase the R's roles, which includes, people may remember early in the year, for the first time being able to include some GP roles within that. We know this is not a fix for the workforce, but it does allow us to continue with the additional role reimbursement scheme as a means of increasing capacity within the system. The bottom left, just picking up, shows you where some of those growth in, on the right-hand side, shows you the different types of roles within there where we've had some of the expansion. And what this shows you is that as well, we've had circa 1,800 more healthcare professionals employed over the previous 5 years. A big theme coming out nationally on this work has absolutely been around training and education. And I think we do have a challenge that we're continuing to look through here, how we can grow our general practitioner workforce. There's absolutely interest in the training places, but what we struggle with is the capacity in general practice to host the number of trainees that we would like to see to grow that workforce. So that continues to be an area of particular focus. And what you can see on the bottom right there as well is that we are seeing new entrants into general practice, so 207 GPs and 78 nurses in this reporting period. Just picking up the estates issues, a little bit more detail. We've been doing surveys across all of our general practice estate. And what this is identifying, and we've explored this in detail at the Primary Care Subcommittee, is the potential to create additional capacity through our modernising our estates. This would allow us to house additional staff who are already employed, but provide clinical spaces where they can have more patient-facing activity. There is limited capital funding available for this, so we're currently going through an exercise of prioritising the funding against the premises surveys for where will we get the biggest bang for our buck. But theoretically, if we were able to convert all of the additional space identified into clinical space, it would give us the physical capacity for 1.4 million additional appointments each year, with minimal revenue implication, as this is making use of existing staff by creating additional footprints of the buildings. This is a longer term piece of work, and the outputs of this will be completed before March 25, so our forward work plan should be clearer. I would just note on that estates issue, we've had some helpful discussions. We're quite constrained by how we can use capital within our general practice estate. What we want to explore, alongside the dentistry work that Dave Gallagher mentioned earlier, is pharmacy. This is another area, building on pharmacy first, where we could create additional consultation spaces to see more people, but the guidance is quite limited in that factor. So we're exploring what flexibilities can we do within the organisation to support this. In terms of cutting bureaucracy, this is obviously this is about taking pressure off our general practice clinical staff and looking how admin and duties can be transferred in other ways. And the national guidance focus on 4 key areas. This is onward referral to other services, the role of fit notes and discharge summaries, call and recall, and clear points of contact. And you can see that the baseline self-assessments we've been doing with acute trusts in the bar chart shows us where we've still got a bit more work to do in understanding the potential there. And the ongoing GP collective action really shines a spotlight on some of these interfaces. So the potential actions that were in the BMA list of 10 possibilities does include some of these referral routes, moving from digital to paper referrals. How do we manage advice and guidance? Potentially looking at fit notes. So this is an area that we'll keep a very close eye on, because it could potentially deteriorate. Next, only 3 more slides to share with you, but really want to obviously keep the focus on outcomes and experience as well as activity. So this slide shows you a summary of the GP national survey results. This is just an extract. There's a whole raft of indicators in there. And whilst, of course, in the North East, we're always very focused on, being the best at getting better and trying to keep improving our performance here, we are above the national average in all areas of the survey, which is heartening to see. And on the right-hand side, you can just see that we've had an increase in the number of practices submitting friends and family feedback, which gives us a better baseline to measure against. And interestingly, just 1% up and down in terms of positive and negative. But in the main chart there, you can see, as I say, where we continue to be above the national average. The areas that really stand out for us in terms of how easy or difficult it is to contact your GP practice is a kind of 50-50 easy versus difficult, so a bit more for us to do in that area. The next slide talks, just gives you some overview again of some of the patient survey information we've had. This has just come out in the last few weeks, and we use an independent company to assess our current patient experience. So you can take this alongside the GP survey for a little bit of triangulation. And it does highlight where we need to improve some of the work we've been doing. So just taking a couple of points from these slides, you can see on the first one, respondents are not reporting any particular changes in ease of accessing appointments in the last 6 months. Some saying worse, some saying improved. So although we're seeing more activity, we need to constantly review how easy it is for people. We found that the majority of phones were being patients contacting the GP between 8 and 9%, 65% waiting under 10 minutes, but that still means that 35% are waiting over. So again, managing that so-called 8 AM rush continues to be an area we wish to focus on. I've already mentioned earlier the NHS app, and there's a bit more work to be done here around the ordering of repeat prescriptions. That's having a good uptake, but it's not working in all practices, in all localities, and for all patient groups. Particularly, we've heard from our patient experience, some of our older users are finding it harder to navigate if you're relying on a digital route. So we continue to look at ways we can improve this. Appointment suitability. Generally, patients are reporting that they've got some flexibility of appointments. But we know, again, those for people outside of normal working hours, although we may all question what normal working hours are in the room, but certainly outside of the 9 to 5 is something that we continue to look, and practices have systems for triaging and managing activity outside of those hours. And then final point on there is the pharmacy first. Again, I've touched on that earlier. And it may be, Chair, that we revisit this one later in the board work programme to bring a bit more detail on the Pharmacy First programme, but been a real success story in the North East and North Cumbria. And then finally, I just wanted to finish with some of the challenges and next steps. So this just gives you a sense of what the challenges to manage at the moment. So again, GP collective action, what impact will that have on our planned milestones for the remainder of the year? A little bit of work around the data flows for pharmacy and Pharmacy First, being able to understand the referral from general practice, what was the disposition route for that patient, and the outcome allows us to continually refine those pathways and make sure we're maxing the opportunities. There's been a little bit of delay around some of the digital frameworks, but it's not significantly impeding that work plan. And then a key aspect, again, partly linked to GP collective action, is our primary and secondary care interface meetings that we have between our medical directors and the MDs within our foundation trust, doing a bit of work to reinforce those. If I'm honest, they are variable in frequency, attendance and outcomes. So we're just sharpening up the work plan around there. And then at the bottom, you can just see some of the next steps of where we're focused on for the remainder of the year. Thank you. Thank you very much, Lee. That's a very thorough report. It is just an update item. You'll be hearing more again. So at this point, questions and comments? Okay, thank you. Well, in the interest of time, receive your report and we'll move on. And similarly, the quality strategy we've discussed before, David. So this is a...
We have indeed. Thank you, Liam. So the quality strategy has been in circulation for over 8 months, and we've had excellent engagement from the system, and we've had over 718 comments in terms of the strategy. A lot of those are around simplifying some of the I statements to make them easy to understand, and we've done that. And then there's many of the comments from the public stated that whilst the statements made sense, they were not reflective of their experiences, or they commented this did not happen in reality. So I think it's really important then that the quality strategy reinforces the need for us to set the standards of what people have a right to expect when receiving care in our system, but it also gives us a great example to use with providers for the need to work collectively to improve and have a joined-up quality strategy across the system. And it may also look at how we target some patient and public engagement work driven by the strategic themes in the strategy. So in terms of the headlines in this, it's our strategy of better health and wellbeing for all. Our vision for the North East and North Cumbria is better, fairer health and wellbeing. So I think it's really important that this inclusive vision capturing the need to improve health and broader wellbeing for everyone across the North East and North Cumbria. So our aim at being the best at getting better, we've already created the Learning and Improvement Collaborative to mobilise people from across the region. And it's our intent to build the learning system as a culture, a community and a collection of assets that support learning at every opportunity. And we'll do this by working with people and partner organisations across the ICS. So not only can health inequalities affect people's health throughout their lives, there's also growing evidence that health inequalities, social detriments of health and people with protected characteristics may be disproportionately affected by poorer outcomes, harm and premature deaths. So in this quality strategy, we've added more information on health inequalities and increased patient harms. And this includes studies that found people with learning disabilities are almost 4 times as likely to develop sepsis, and that people from the most socio-economically deprived groups were nearly twice as likely to die from sepsis within 30 days than those of the least deprived socio-economic groups. So it's really important that by viewing health inequalities through the lens of patient safety, this gives us a unique opportunity to take meaningful action to reduce the risks of harm and improve the quality of care people receive across our system. We'll do this by working with people and partner organisations across the ICS to support the delivery of our quality strategy. So in terms of our priorities, so each year we'll have a set of equality actions and priorities. Each one will have a dedicated executive director lead from within the health and care system to provide leadership and oversight of the improvement journey. The quality improvement activities will be driven by a patient safety centre and will include learning events, shorter timescale quality improvement projects and systemic-wide improvements we want to focus on. And the timescales of those large-scale system-wide priorities will be determined for each priority. This will enable us to have a wider impact across organisational boundaries and our system. So in terms of our strategic themes, we've shared this before in terms of those 5 themes. The National Quality Board published a shared commitment to quality, and quality care is understood in the guidance as care that is safe, effective, provides a personalised experience, is well led and sustainably resourced. So normally you'll normally find on there, as we said before, patient safety, clinical effectiveness and positive experiences. We've included 2 overarching strategic themes of culture and climate and clinical and multi-professional leadership, as we think these 2 areas are key components in delivering a quality system. So in terms of culture and climate, so it's long been recognised that culture of organisations or the system shapes the values and behaviours of everyone in it. The quality of care it provides and its overall performance means that ultimately culture matters if we want to consistently deliver high quality care and continually improved. And despite many reports being written on the importance of safety cultures within the NHS, there is still much more to do to ensure that safety and high quality care are consistently delivered to reduce the risk of avoidable harm. And we've seen through multiple CQC inspections, independent investigations, that closed cultures can happen anywhere. So it's part of our role to ensure that we tackle closed cultures. And so therefore we'll foster a proactive and positive culture of safety that is based on openness and honesty, in which concerns around safety are listened to, safety events are investigated, and lessons are learned to continually identify improvement and embed good practice. So it's really important how we create that culture that we strive for within the North East and North Cumbria, that these factors and behaviours will help us build a safer culture, drive positive health outcomes for our citizens. To help us achieve this, we have defined values and behaviours we will adopt. with some enabling factors enacting behaviours for the system, organisations, services and individual members of staff. These will be key in creating the culture and climate we aspire to. So from a system and organisations, that's leadership commitment, working together with collaborative decision making, aligned vision and values with shared endeavour, and shared commitment to system-based performance and priorities. So for services and teams, teamwork and cohesion, psychological safety, and clear defined and embedded systems to keep people safe. And then for individuals, safety, knowledge, expertise and skills, and what it means for us as a system. So the standards that we and values we set for ourselves. So in terms of the next few slides, they're all around kind of what this means for us and how we've designed all these themes. So in terms of patient safety, is a priority for everyone and leaders within the system and better culture of openness and collaboration. In terms of clinical effectiveness, as a system, this is the way we work together, which maximises the potential to improve patient outcomes and health based on evidence-based practice, continuous improvement and monitoring of clinical outcomes. So from clinical leadership, we'll build capability for improving by providing multi-professional leadership for quality and building learning and improvement cultures. And then just the next slides are around foundations and next steps in all strategic themes. And these are to help people visualise how we can make quality strategy a reality. We have developed a foundations and next step approach, and this is intended to show some of the work that we're already doing that support the delivery of quality strategy and some of the things we have planned. So we've also included in this the quality governance framework that will underpin the ICB's approach to quality governance across the organisation and wider system. And so once this is published, we'll be looking at developing our system quality priorities and launching the Patient Safety Centre.
Thank you very much, David. And we've got copies of the slides we can refer back to. Just because of the online audience, we do have to keep to our time slots for the breaks and the restart. So we're now going to break for half an hour, returning at 12:05. Thank you. go? Good, thank you. Well, so resuming with the Integrated Care Board for North East and North Cumbria meeting of the 1st of October, we are restarting with an item on population health. But before I do that, we finished on the quality strategy, and I just wanted to check that people were happy to approve that. And then, given its importance, I think probably at the next meeting of our board, which will be in 2 months' time, we might have a discussion about how the early stages of implementation are going. That gives you the opportunity to have a fuller discussion of it at that meeting. So thank you. So item on our ambition to improve population health, and Neil O'Brien, our Chief Medical Officer, is going to take us into that.
Thank you very much, Chair. So, yeah, I'm going to try and take you through a presentation which really highlights the work that we've been doing to date on improving our population health. And there's a lot of this aligns to our ICP strategy, and you'll see some of these goals within the presentation. Within the work that I'm going to discuss, there'll be the work that we do under the banner of Healthier and Fairer, and also there is the final draft for your agreement of the clinical condition strategic plan within your pack that will be seeking agreement for, and then we'll go out into the delivery of that. So the presentation is so it's, as I say, about our ambition of improving the overall population health. And the many different ways in which, as an ICS, we are attempting to both improve life expectancy, healthy life expectancy, and reduce health inequalities in our region. Now, this slide just really states that it's not the individual job of the health service to improve our population health. There are many different ways in which we can try and address this, and these are helpfully broken up into these three broad areas, which are civic level interventions. That would be something like lobbying on tobacco legislation, community interventions. We are using our social assets around healthy environments, getting people back to work, and that's absolutely the remit of our place-based health and wellbeing boards and their commitment to improve their population's health. And then the third one, which is the bottom right, is service-based interventions. So the things that the health service or and partners can actually do to improve the population, and that's really where our clinical condition strategic plan concentrates. This slide, which you might find it difficult to see from, but we'll circulate the slides later, shows that there is obviously a gap with our both the life expectancy and healthy life expectancy. This graph just shows men, just to illustrate the points that I wanted to make. Our ambition is by 2030 to reduce the gap in life expectancy for our ICB compared to the England average by 25%, and also reduce the healthy life expectancy. Now, to do nothing, the next slide will show you is not an option, because these actually widen if we do not plan to both use all of our assets and the assets of the health service to try and narrow this gap over the coming years. This slide shows the females' data, which shows that basically the life expectancy is predicted to increase to a gap of 9.2 years by 2030. And the healthy life expectancy gap, again, was to widen. Now, we've got a lot of programmes of work to try and help reduce this over this period of 5 years, and I'll detail some of this in the coming slides. The other cost, yes, there is the cost to the individual in their life expectancy and the healthy life expectancy. However, there's also the cost to the NHS and to society in broader terms. The graph on the left there shows the missed cycle of opportunity for not investing upstream and investing in prevention, both primary prevention and secondary prevention. It then leads to poor health, and the health service then becomes focused in managing people who are in poor health and have disease. The one on the right just illustrates some of the societal cost of the burden of ill health. About 1.6 million working days lost per year in the North East and North Cumbria, leading to poorer productivity, lower growth, and then issues within the economy. So this again aligns with the Darcy work about that the NHS's contribution to getting the population healthier and more productive. So the next section just really details the work that we're doing with partners around the wider social and economic factors. This is quite a busy slide, but effectively there is variation within our region. The life expectancy and healthy life expectancy figures that I've just shown you are the averages. There is great variation within the North East and North Cumbria, and we need to tailor our approaches to those at greatest need. But there's variation in the region in sickness, employment, those that are claiming benefits, children who are living in poverty, and the average income. And all of these wider determinants actually, have huge impact on people's health and well-being. So what are we going to do about it? What's our ambition? The Healthier and Fairer programme has been up and running now for some time. It is co-chaired, it's a partnership board, it's co-chaired by myself and Amanda Healy. It has broadly 3 pillars which are focused on prevention, the health and healthcare inequalities, and the broader social and economic determinants. Those groups are all co-chaired by clinical leaders and directors in public health, because to try and really understand that it's not just the health services job to own the improvement in these areas. There are a lot of wider determinants that we need to address. This first slide starts to talk about our approach to prevention, and this is the slide detailing healthy weight and treating obesity. The World Health Organization states that obesity can't simply be seen as an issue of personal responsibility. It's a critical health, economic and societal issue. There's a lot of new technology coming around in this space, and some of the new medications that we will need to think about and address. But also, it's not just about the treatment of obesity, it's about ensuring that we work with our partners to make sure that the environment for people to lead a healthy lifestyle is promoted, and therefore people can hopefully not get to the point of being obese in the first place. To this end, we are developing a North East and North Cumbria obesity strategy. We'll also be looking at a pledge where we will be trying to get all partners from across the North East and North Cumbria to sign up to real collective action on trying to improve the rates of healthy weight across the North East and North Cumbria. We're working on that strategy now. Once we've got that, we'll obviously bring this back to board. But in addition to this, there are specific things that the health service can do. We're looking at access to Tier 3 weight management services, access to digital weight management tools, and we'll promote these, but bring them together in a strategy which also will take into account the availability of the newer weight loss medications when they become available. Next is alcohol. Again, alcohol is a significant problem for us in the North East and North Cumbria, with men being much more likely to be admitted to hospital with alcohol-related illness than women. And there's a great unmet need in the treatment of people with alcohol problems across the patch. Now, why there is an unmet need is, yes, some things around the availability of services, but people actually aren't aware that maybe they're drinking excessive amounts until they start to come into problems with either their physical or their mental health. We've got an ambition in the North East and North Cumbria to reduce alcohol-related admissions by 15% by 2030. And there are some plans in place for us to do that. mainly around the implementation of alcohol care teams, work with our communities so that people can identify when they've got taking unhealthy amounts of alcohol, working with our strategic partners across the North East and North Cumbria to raise the profile of this, and then targeted approaches for those communities that are experiencing higher levels of alcohol intake. The third big pillar of our prevention strategy is on tobacco and smoking prevalence. Although there's been great work in the reduction in smoking prevalence, is still sitting at around about 13% across the North East and North Cumbria, but this varies in our communities. Our aspiration is to get down the absolute smoking prevalence in the North East and North Cumbria to 5% by 2030. Now, this is going to take a huge amount of effort, and I think probably a slightly different approach to what we've been taking to date. We need to focus our efforts much more on the communities that have the higher prevalence, look at the ways in which we are engaging with those communities. There's some great examples around the work where we're engaging people who have maybe got significant mental health problems and offering them dedicated smoking cessation advice, but we need to do more in this space if we're going to hit that target. As I say, we are working with partners to do that. The Core 20+5 is the framework in which we're looking to health service-based interventions in reducing health inequality. And within your pack, apologies for the amount of information, but there is a whole load of work going on which actually really is tailored towards the Core 20+5 aspirations for both adults and children. And these conditions are also reflected in the Clinical Condition Strategic Plan, so they're pretty much all covered in there. So our aspiration is to reduce healthcare inequalities associated with deprivation and ethnicity by 2030. We haven't put a number on that because it actually varies depending on the condition, but the detailed plans and our interventions are all within your pack. The third pillar of the Healthier and Fairer group is the wider determinants and what can we do in our communities to improve housing, employment, reduce levels of poverty, health literacy and digital inclusion. And again, because of time constraints, I won't have time to go into all of the work, but suffice to say, we have groups that are working across the system, looking at all these very important areas that impact on people's health. So I want to move now to the Clinical Condition Strategic Plan. You have in your pack the final version, and just as a quick reminder, the Clinical Condition Strategic Plan is a population health piece of work. It looks at the most prevalent conditions across the North East and North Cumbria that have the greatest impact on health inequity and the health of the population. And what we've done is we've gone further with that, and we've actually looked at what could the health service do better to actually improve the outcomes within each of these different priority areas. Now, for adults, the adult priorities are lung cancer, which is one of the main causes of reduced life expectancy in women in the North East and North Cumbria. Anxiety and depression, we've already heard about that earlier in the board meeting. Respiratory disease, cardiovascular disease and lower back pain. And within that, we have put some very, very specific measures and what we want to see in improvement terms in how we deliver care for these people. And then in addition to that, we absolutely want to make sure that our offer is much more robust in those areas of the population that are maybe from deciles 1 and 2 or from populations that normally struggle to access healthcare. This is the children's priorities. There are 7 conditions within the children's Core 20+5, and they are reflected in here. And again, you can see they are asthma, diabetes, epilepsy, oral health, anxiety, mental health, and then obesity. It was felt very strongly by the clinicians that we engaged that obesity was seen as a clinical condition for children that requires dedicated focus on both the prevention and the treatment of children with obesity, because it absolutely has a huge impact on the life course of children. And again, underneath all of these areas, there are very specific interventions that we will implement over the next 5 years. And hopefully, if we do this for both adults and children, we strongly believe that we will maximise the benefit of reducing health inequalities, improving life expectancy, and that really just speaks to the bit that is the service level improvements within that triad that I showed you earlier on. This is a busy slide, not for you to see, but within the Clinical Condition Strategic Plan, what we now have for every single priority area are the things that we will measure. And the things that we will measure and we will report on and report back to board, so you will have confidence that we are actually implementing what we have said we will do. Now, it's taken a long time to develop these metrics, and there are lots of them. So when they come, we'll put it in a format which is easy to see the highlights and where some of the challenges are. We've worked with NECOS, we've worked with Public Health, we've looked at all of the data sets that are available to us, and it's not perfect, but we think that we've got a very robust set of metrics now that we will be able to report on, and we're working with business intelligence on exactly how we do that and present that. So I've hopefully detailed a little bit about what our health challenges are. There is a gap. We've got an aspiration to reduce that gap. It's not going to be easy. We know that, that the Darcy report is absolutely talking about moving the left shift and really investing in prevention, which is absolutely covered within our clinical strategic plan and also the work of Healthier and Fairer. So if we deliver our Healthier and Fairer programme and our clinical condition strategic plan, I'm confident that we will make real progress in both our life expectancy and the health inequalities in the North East and North Cumbria. So I'm happy to take any questions, and that's just the plan on the page, which I'll leave up there for our clinical conditions strategic plan.
Thank you, Neil. We'll open it up now to questions and comment. Yes, Tom Hall.
Just thank Neil for the presentation, really comprehensive. I think just to add a little bit of flavour to the kind of partnership work, and as Neil said, the presentation's really covered that kind of NHS contribution to wider prevention. Just thinking about where that interfaces with some of the stuff that we're doing at a local authority level. For example, work on the wider sustainable food environment, the work we're doing trying to build networks of community shops and looking at how we create sustainable, healthy food for children, young people and families in places like South Tyneside that obviously I represent. The wider work that's going on around tobacco and tobacco control, obviously we're aware of the tobacco and vapes bill now making its way through the parliamentary system. You know, we've really tried to lobby and advocate for that to be picked back up in the new parliamentary session. So there should be some really tangible outputs from that. Particularly for the local authority 7, we've just published through our jointly commissioned programme Balance, the new manifesto on alcohol that has been shared with the Secretary of State and supported by key leaders in our local system, not least Kim McGuinness, our new mayor for the region, which is really advocating that wider system approach to alcohol, trying to increase alcohol duty, bring forward a national strategy around alcohol, lobbying for the introduction of the minimum unit price, taking on board the lessons that have been learned from Scotland. So if we can see all these different elements, how well they've been coordinated around this programme of work, I think it's been excellent to see. I've obviously been pretty close to the clinical condition strategy development as well. Neil's seen it through its various iterations. It's really excellent to see the performance matrix that's falling out of that. I've got to ask, is there going to be inequalities monitoring as part of that framework as well, including looking at different black and minority ethnic group populations as well as deprivation?
Yes, absolutely. I mean, as Jacqueline was saying before, a lot of our performance metrics, we look through an inequality, ethnicity lens, and the same will apply to these.
Thank you. Sarah Malik.
Thank you, Neil. That was an excellent and very insightful presentation, I felt, with a lot of data. So I just had three thoughts that I wanted to share with you. First is obviously thinking back to what Sam said at the start about the workforce 1 in 4 being from an ethnic minority background, and obviously that will play into our regional health figures as well. Do we have an offer for our ethnic minority staff which might help us kind of be ahead of the curve on this issue? My other thoughts were that obviously that slide of kind of the late diagnosis of lung cancer always strikes me and it makes me feel a bit sad, but obviously over 50% were diagnosed at stage 4. And it just made me think about the access general practice has to diagnostics. And obviously I know there's been a lot of work done with community diagnostic centres. You know, have we done some work on kind of understanding where our highest rates are and what the access to diagnostic centres are for general practice in that regard? And finally, I just wanted to touch upon children's oral health, which again is always a startling bit of information I find. But there's research papers and studies that clearly state pain, infections, poor sleep and eating patterns, as well as increased school absence, are also a consequence of poor oral health in children. And I was just wondering upon the prevention programme, which I know a lot of work has been done and Dave Gallagher has led on this, but in our prevention box it stated about supervised teeth brushing, and I just wondered whether dentists in schools had been considered as a possible solution. And I know we're not here for solutions, but you just wonder what else could be done to rectify this.
Yeah. So on the offer for ethnic minority staff, we haven't considered that as part of this work, but we can certainly take that away. For the lung cancer point, diagnostic access, so the two things that we are going to measure and improve will be rolling out 100% coverage of the targeted lung health checks earlier than the 2030 planned date, and also improve access to basic diagnostics. So they are absolutely on the list to improve. There's some work going on already with that through the diagnostic workstream, but we will make sure that we address, and I'm aware of the inequity in access across the patch. For oral health, a lot of the initiatives within the clinical condition strategic plan will be delivered through our other work streams. I don't know, David, if you've got anything you want to talk about the children's oral health.
Yeah, I think the key bit is, and it links to it's probably Tom's point, this is a wider issue, as are all of these issues. So each of our local authorities have oral health strategies, so we're working very closely with them. And while we try to tackle the access to dentistry challenge that we've got, we're also trying to look at improving oral health. And indeed, last year, we put some non-recurring funding into supervised toothbrush and fluoride varnishing, etc. So lots more to be done, but I think it's Neil's point, this joins a lot of things up.
David Stout.
Fine. Neil, really good report. Very important topic, very comprehensive report. Thinking about the implementation of the recommendations, and it occurs to me there's performance managing the implementation of the recommendations and then monitoring in due course the effectiveness of those. So put that to one side. But looking at the recommendations, it seems to me, and I'm not close to this at all, that some will be easier to do than others. But nevertheless, some will be quite tricky and will involve resources, which we currently don't have and haven't had for a little while. And I wondered what your plan was. You know, does that entail, okay, just doing what you get as much money as you can by, bidding for funds, trying to get a bundle of cash within a financial plan, with a strategy dedicated to this particular topic, pacing it. I mean, I wonder what your plan was, because although it says we will, I can't imagine you'll be doing all that from the 1st of April. So it's what you do around implementing the recommendations.
So yes, it's a great question. I think what this piece of work has done, and what it will allow us to do, is prioritise our efforts and investment around. If we do it around these areas, these will have the biggest bang for your buck, if you like, in reducing health inequity and improving the general health. Now, a lot of them in there I would class as relatively low-level things to do, things that are done quite commonly in general practice. And if we just slightly change our focus of effort to delivering some of these things, then the actual cost of delivering those shouldn't be too high, yet the benefit will be realised. There will be some areas that will require investment. I mean, one example at the minute is our access to spirometry at the moment across the North East and North Cumbria is patchy in some areas and will require some investment. We're absolutely sighted on that, and it's quite frankly, it just needs to be addressed. So I don't think there's anything within the clinical condition strategic plan that requires massive investment. I think it's a change in focus, slightly look at a different way of the way in which we deliver some of our community services and some of the hospital services. So I don't think there's a massive investment required.
Great.
John Pearce.
Thanks, Chair. So my question was about the opportunity to tie into other national agendas and what that might bring, both in terms of priority focus and also potential funding. So thinking about in my area, Department for Education have a big focus on children's school attendance at the moment, and developing and testing out attendance action alliances as a multi-agency approach to improving attendance. And if you think about how a number of these conditions will impact on children's attendance at school, an obvious one being oral health, and some of the pilots that have been operating around supervised teeth brushing at school and various other routes. There's potential opportunity there to tie up and have that conversation cross-government and at a local level, cross-sector into our schools to talk about actually how do we maximise the opportunity to both have an impact on some of these long-term conditions, but also have a benefit for schools in terms of improving school attendance, which is probably the biggest priority nationally for schools.
Thank you very much, John. Sam.
Thank you, Chair, and thank you, Neil, and also to Amanda for your leadership of this. It's an excellent piece of work. My question is about innovation and implementation, and slightly picks up one of the points Sarah was making around diagnostics and access to diagnostics. So thinking about the future and thinking about diagnostics, so you can go and you know, be put through a scanner, but actually we're seeing an increase in the market of home diagnostics. And so I'm thinking, what do we we got a sense of sort of the one or two big innovations that would support delivery of this plan, and if not, what do you think we need to do around that particular kind of innovation area now?
So I think that the two that really jump to mind are I mean, a lot of people have wearable technology now, and ways in which they can monitor their own health at home through either blood pressure or doing their own ECGs, even from a wristwatch. So certainly in some of the cardiovascular disease detection for the cardiovascular priority, I can absolutely see how we could try and harness new technology and innovation. And again, you know, where previously I would have had to refer someone into a hospital for a recording, a 24-hour tape of their heart, we could now, why can't we download the information from their wristwatch? So those kind of things, we can absolutely look at how we capitalise as much as possible. And then the other one is around respiratory illness and spirometry. There is a lot of work at the minute on artificial intelligence around some of the interpretation of spirometry, which can improve diagnosis and therefore improve treatment, which at the end of the day is exactly the intervention that we are after within respiratory illnesses for adults and children.
We haven't got much time, Neil, for it's a very interesting topic, but I just wanted to make one point. That strikes me that these areas have very little visibility with smoking, alcohol, obesity. There's very little out there highlighting the work that's going on, and that isn't just about keeping people informed. I think it's establishing societal norms for some of these behaviours. And I think the other thing that I wanted to say is that I think one of the big themes in the next few years is in this area of changing behaviour, because otherwise the health service is going to run out of money. They're just not going to be able to afford. Look at the percentages you were showing in some of those. And I think the big theme, the big skill that's going to be required is activation. How do you activate people to follow healthier behaviours? And that's different to giving them information, persuading them, advocating. it's finding that thing that will activate people. And if you look at one very good example, it would be the park run movement, which is worldwide, as you know, happened very quickly, and the way in which they activated people that wouldn't normally engage in that is very interesting. So I think we should be looking at some of these areas, because there are the technologies, the preventive interventions, but mass behaviour change is the other factor, and it's virtually non-existent really right across the NHS, I think, and certainly at national level we're not getting much in the way of action either.
Just quickly on that, through our Waiting Well approach, we do use individualised patient activation scores and initiatives to try, but you're right on that wider scale, but we're looking at the opportunities of taking that approach to looking at overall health promotion through either some of these more medical interventions, because Waiting Well's been very much looking at lifestyle interventions, but on activating people to look after their health through maybe engaging more with health services through a similar kind of approach. But
okay, well, thank you. We'll move on now to item 17, which is the mental health, learning disability and neurodiversity item, and moving on from that shortly after that is item 17 point, which is the review of intensive and assertive community mental health care. So there's some conflicts of interest to be announced before I ask Levi Buckley, our Chief Delivery Officer, to start off on this. First of all, and I'll use you'll probably be using the two acronyms as well, rather than spelling them out each time. For those who are listening online who don't know our part of the world, CNTW is the Mental Health Foundation Trust that covers the northern part of the region, including Cumbria, and TEWV, TUV, it's usually expressed as, covers the Tees Valley and some of the southern parts of the region. So those two acronyms will be used, I'm sure, several times during the presentation. But Rajesh Nadkarni, one of our partner members, is Medical Director and Deputy Chief Executive Officer of CNTW, so he has a conflict of interest there. And Rajesh's wife works for TUV, so a conflict of interest there. Tom Hall's wife works for TUV, and Rajesh is going to abstain from decisions in approving the improvement plan. And their conflict of interest is carried over to item 17.1 and added to those three. Our Chief Executive, Sam Allen's sister, works for Northumbria Healthcare NHS Foundation Trust, and Sarah Malik is Medical Examiner for Gateshead Health NHS Foundation Trust. So everybody who's been mentioned can remain in the meeting and take part in the discussions, but with those caveats related to decision making. Okay, so Levi, over to you first of all with the item 17 on mental health, learning disability and neurodiversity.
Thank you, Chair, and I've not seen such a conflicted item, so hopefully we can manage that through the discussion. So I think everything we've been discussing today, whether it's been the clinical condition strategy, some of the themes coming out of the deep dive in the integrated delivery report, reflections on Lord Darcy's investigation, Healthier and Fairer, our ICP strategy. We'll be hearing from our chief nurse about the lead review. You can see it all focuses in on a lot of this work we'll be talking about in the next 20 minutes or so. Board members will have seen there's quite a detailed improvement plan which has been developed with partners across the sector. It has been built up, torn apart and built up again through our Mental Health, Learning Disability Subcommittee, which includes our two expert by experience groups, and it's also been scrutinised by our Finance, Performance and Investment Committee. So it's had a lot of challenge to get it to the current position. Before I take you through some of the key points, I'm just going to introduce you to our patient story. We're going to hear in a moment from Les. Les has a mild learning disability. and an emotionally unstable personality disorder, as well as type 1 diabetes. Over the next 4 minutes or so, you're going to see and hear about his journey from being in institutions over many years to now living independently in his own home with some wraparound support. And you'll hear how Les tells us about how important it was people listened and worked with him throughout his journey. We have got express permission from Les to share his story, and we think he may indeed be watching the live stream. So if you are, Les, thank you for allowing us to share your story with the board today. And I just thank Inclusion North as well. They're one of the groups we work with to bring patient voices to our work, and they've supported Les in telling his story as well as wider advocacy work in our system. So thank you. So I think this was helpful to remind us as we go through some of this. This is about people. We focus on numbers, whether that's activity, money, performance, and rightly so. Those are all parts of ensuring we meet the needs of our population. But behind this are individuals, families, communities. And what you heard there from Les is he wants the same thing that everybody in this room wants, an independent life, fulfilled and achieving as much of your potential as you can. And I think, sadly, what I hope the report in the papers today demonstrates is we've got some way to go in helping everybody achieve that potential. So, inevitably, this plan will focus on our approach to developing services. It will talk about how we may look at our investment profiles and what we might do to mitigate some of the capacity issues. As I say, I just ask you to keep in mind for the board that although we're focused on activity today, we do spend a lot of time looking at outcomes and experience measures of people using our services, including the role of our 2 expert by experience groups, although we'll not have as much time to look at some of the outcome data today. The improvement plan is really trying to address these 4 areas. So looking at the gaps in our current provision of services, really focus on those client groups where we need to provide some clarity of what our offer is, improving our approaches so that they can flex up and down depending on both the severity of presentation, the locality in terms of what is that local infrastructure of services that's available, and some of those specific challenges. I won't dwell on this slide. We heard from our Chief Executive earlier about the independent investigation by Lord Darcy, and this quote from the Royal College of Psychiatrists in response just recognises really that Lord Darcy's investigation laid bare the scale of the challenge facing the NHS and really puts that balance hopefully back in terms of the balance between mental health, physical health, and the impact for all of us and our communities and populations. In the report, you'll see some of these statistics. These are, again, taken from the independent investigation, and they just give a sense of the scale of the national challenge. And Lord Darcy himself said here, if you just look at the growth in the demand for ADHD assessments, it's so significant that it completely overwhelms the available resources that we have. So this really shows that there's that increasing demand. We're seeing the impact on waiting lists, both waiting list size and the shape. We're seeing particular challenges around some aspects of our diagnoses, particularly for neurodevelopmental. And then the risk that we're seeing in equities, again, going back to the clinical conditions strategy and coming on to the leader review later, for people with learning disabilities having a significantly reduced life expectancy with the rest of the population. And then finally, their workforce, how we grow and manage our workforce with the right skills to meet this challenge is part of what we're discussing today. Just looking at it from a regional perspective, very much echoes the national picture here. So we see demand exceeding capacity. We see that the performance data, as we heard from our Chief Strategy Officer before, we are ahead of the curve here in reporting it and getting some visibility and transparency on that. But we know there's probably gaps in there, so we'll continue to refine that approach over the coming months. And then we have a recurring theme about whether our investment has kept pace with the increase in demand. And people in the room will be familiar with parity of esteem. They'll be familiar with this being everybody's business. So how do we look at this in the round, not just through a mental health, learning disability lens? We heard from Jacqueline earlier about some of the deep dive on the data, so I won't dwell on that today. However, there are some green shoots. I think we are beginning to get a sense that the huge increase in demand that we saw post-COVID is beginning to plateau. I wouldn't for one second be complacent and suggest that it's all been fixed at the moment. But what we can see is in terms of dementia diagnosis, 68%, perhaps not where we would want to be, but exceeding the national target. We are achieving our targets around learning disability annual health checks. And again, going back to the risk to life expectancy for this population, this is critical in terms of getting them into the right pathways. We've seen a significant reduction in out-of-area placements, with both our main providers, which has a huge impact in terms of maintaining contacts with families, communities, and helping people on their discharge pathway. Beginning to see some data around the early signs of improvement, both in Tees Valley and County Durham, from our further integration of community mental health services. And you can see that in terms of managing people's needs better in a community setting rather than needing to go into more specialised secondary services. And finally on the slide, talking therapies. Again, we heard earlier, the access rates and referral rates are perhaps not where we want them to be. However, when people are getting through the talking therapy services, the recovery rate is positive and higher than the national average. Hopefully the report demonstrates, we need to be clear about how we're going to address some of these challenges here. Yes, I will be making a plea for us reviewing our investment profile, but money won't solve every problem we have. It is everybody's business, and again, reinforces it's not just about our mental health providers. We know that 93% of our activity relating to mental health is undertaken within primary care and community settings. We know that our acute hospitals are managing comorbidities, including mental health presentations, not just through emergency departments, but across the services they provide. Again, I will be a broken record. So many times I can get parity of esteem in, but how do we look at what we're providing, and do we satisfy ourselves that we've allocated resources accordingly? We continue to see underperformance against national standards, and it does feel fairly endemic, and that's an area we continue to work through with our recovery groups we have with our providers. There is diagnostic capacity, particularly on our ADHD and autism pathways, where the rigour of the clinical assessment can be quite constraining in terms of getting people through pathways in timely ways. We continue to see high levels of death by suicide in the North East, and although our Directors of Public Health lead on local suicide prevention, the Integrated Care Board has a role as well in coordinating work with partners in that area. And again, I mentioned some of the workforce constraints. So the next section is just going to take the board through some of the areas that are explored a little bit more detail in the plan. And there are a few components to our improvement, what we want to see here, what are some of the foundations. So that rigorous performance management being in place, and we heard that the new minimum data sets being refined. If we don't know that we're counting and measuring things properly, we can't demonstrate where we're making improvements or where we need to take further action. We're looking really here at incremental improvement across the board. There are very few big wins that will suddenly eradicate a waiting list or manage demand in a different way. So while we look at the large-scale transformational work, we need to keep making our incremental continuous improvement in a number of areas. One thing we are good at in the North East and North Cumbria is sharing best practice. Having two large providers, as well as some services through our Acute Foundation Trust, means we've got a good network where we can see who's doing things well, how can we replicate that, that concept of shamelessly stealing. We do have investments to expand our key services, and I'll come on to a little later the additional resources we've put in during the current financial year, and you'll see one of the recommendations is around the approach to reviewing our investment profile for years 25, 26 and beyond. And then just to note again, the role of our experts by experience. We have a mental health and a separate learning disability and autism experts by experience groups, independently hosted, who've also offered us their views on the areas that we need to get better at within this work. So I'm just going to take you through our 4 key areas that you'll see in the plan. The first one being around children and young people. And this often gets a lot of, rightly, media coverage. We will all have seen, not just locally, but nationally, the significant challenges, particularly post-COVID, but around anxiety, for children. It affects school attendance. It affects them achieving their potential. It links clearly with our strategic goal around best start in life. And we know that we have a lot more to do here. I'm sure John could talk to us about the SEND inspections. So although we've had one recently in Durham, they're taking place across most of the North East and North Cumbria over coming months. And they continue to highlight challenges in terms of meeting children's emotional and well-being needs, particularly within education settings, but also in the home. So we have expanded our mental health support teams against the national model. That's a very prescribed trajectory for us in terms of workforce expansion and expanding the teams, but we're keeping pace with that. We've recently put some additional resource into our two main providers, but also into other sectors for increasing our diagnostic capacity for children's ADHD and autism. Really need to keep a tight grip on reducing the waiting times, and part of this is bringing in a trauma-informed care pathway alongside this work, which we've started particularly in Newcastle Gateshead, and seen some good impact there. And then eating disorder services and crisis, a key part of the plan, needs some additional work. In terms of adult and older people services, we've heard about expanding our talking therapies, and we have some clear plans ahead. Really linked in with the maternity and neonatal networks about how do we support further access for perinatal mental health services. We've heard from our providers before about the IPS, the Individual Placement Service. We've seen some huge success there in terms of particularly, again, giving people hope and aspiration, getting them into employment, education and training. This is not just about addressing a clinical condition, it's about that whole person and their ability, wider contributions in society. And then a big part of our plan for the year ahead is the community mental health transformation projects. This includes our primary mental health workers. It includes the recent pilot. We were successful with CNTW going into West Cumbria, which is very exciting and gives us a good model for the future. Building on Leslie's story, if we look at issues around learning disability services, we continue to have high levels of inpatient care in the North East, higher than we would want. We're working extremely hard, both with support from NHS England regionally. Myself and the two chief execs of our mental health trust meet executive steering group every fortnight, and we're getting great support from Sir David Pearson, the national senior intervener, and Tom Carhill, the national director for learning disability and autism. But we have further to go here. The work that transformation team and colleagues in local authority are doing around our housing strategy, which we've heard about here before, absolutely critical. So we're beginning to see some really good successes in getting people out of long-term hospital into the right kind of supported accommodation and packages, but we need to go further, faster there. And then David may touch on in the leader report, but one of the lessons has been around reasonable adjustments. And again, I think we're a bit of a national leader in our work here, particularly Mandy Boardman and Cathy Peterson, two of our GPs who've really taken an excellent clinical lead in driving forward this work. Focusing on neurodevelopmental and particularly on autism and ADHD, again, this continues to be an area of focus. So we did have an event last year looking at some work around system redesign. We've revisited that. I think we need to review our transformation approach here. What is quite exciting is an opportunity for some large-scale transformation work. So we've been piloting something called the Portsmouth Neurodevelopmental Toolkit in North Cumbria. The ICB invested some resources in a one-year pilot. It really is a quite different approach to identifying 10 dimensions of neurodiversity rather than one simple clinical diagnosis. And what's exciting is the engagement of children, their families, and particularly education, which we're seeing in Carlisle. So we've been working with John Pearce and we're with the Directors of Children's Services. We think we might be able to do this at scale on a much larger footprint in the North East and North Cumbria. The benefits of that will be getting the early help and reasonable adjustments to children and young people at a much earlier stage, and we'll have a greater consistent threshold for secondary diagnosis and services. Just coming to the last couple of slides, so a summary of our investment profile for 24-25. We have put significant additional resources in, and our plans, which are referenced in the paper, which will be part of our system financial plan for 25-26, are to include some particularly around our neurodevelopment, diversity diagnosis, continue our transformation journey for community mental health, expanding perinatal, and further resources in both adult and children's services. Hopefully where that will get us to over the remainder of this year and into next year is to continue to see some better performance against our waiting times, to continue to expand the mental health teams in schools, achieve the perinatal targets, and further reduce our inpatient rates for people with learning disability. So the paper, I hope, gives you a sense that we've got a framework for monitoring and evaluating our performance regularly, responding to that. We have plans around focusing on our workforce and service and expanding the capacity in the right areas. A balance between doing more of the same, investing and transformation, and that'll be different for different pathways. Continue to use our voluntary community sector, which is key at a local level, particularly on that early help and getting kind of waiting well approaches, and then continue to focus on our investment profile for the years ahead. So thank you, Chair. It's a bit of a whistle-stop tour. Obviously, happily take any questions, comments.
Thank you, Levi. Any questions and comments? Mike. Mike Smith.
Thanks for the comprehensive report, Levi. One of the points you raised repeatedly was the parity of esteem, which I fully support. And a note in the Chief Executive's report earlier, it was referenced that there's now going to be 104-week waiting times published, and that we have to try and develop trajectories to get to that level, at least in the near future, which I think is very positive, given the state of what the current situation is. Just one question, I guess, is in particular thinking about the neurodevelopmental pathways, which have the longest waits. Is there current processes in place to make sure those with the highest levels of need at the point of referral are being prioritised? I'm conscious if you're on a waiting list for 4 years, we don't want those with the very highest levels of need waiting 4 years, because that could be quite problematic.
I think the short answer, Mike, is no, not satisfactorily. So part of the problem is we tend to see referrals go into one large child and adolescent mental health list. So the nuance of separating out the different presenting conditions has been part of that challenge. Now, we are very cognizant of that, so working with both providers to try and streamline that front-end triage bit so that you can separate out neurodevelopmental from wider mental health presentations. Part of that work absolutely is a risk stratification. So where are the comorbidities? What are the other risk factors? So that our aim is to have a kind of a twin track. So that there'll be a more global offer for more mild to moderate, and then a much more fast track for the most complex to get the help at an earlier stage. But we do have more work to do there.
Sarah Malik.
Thank you, Levi. That was a very comprehensive report, as Mike said. My question was around neurodevelopmental diagnosis. At the present time, we're seeing a lot of our patients, adults and children, using private services for diagnosis, and obviously they then come back to the NHS for prescriptions, which obviously general practice struggle because of the medical legal implications of this. What work are we doing around this, just to bridge the gap of those with the diagnosis, albeit private, but also the ongoing medication and treatment?
Yeah, thank you. It is a challenge, and I think what we're trying to balance at the moment, like ICBs across the country, is how do you manage a plurality of providers within a consistent pathway that all partners know what to be expected and you have confidence in all aspects of delivery. I do think some of that independent sector provision will continue to be part of the global offer, and if used in the right way, it can absolutely bring a lot of value to what we deliver. So one of the examples we're looking at is, as we're going out to some re-procurement in the Tees Valley, is how do we have a a very clear standard of what that offer is, so that any partners, whether local authority, voluntary sector, independent, are very clear of what the expectation is, and we have a consistent pathway of what happens afterwards. So we're very cognizant that that is a bit of a challenge, and I think for general practice, having that confidence in sometimes complex prescribing, there is more work to do there, but it does feature in our transformation work.
John Pearce.
Yeah, thank you, Chair. I was going to talk about that point, but I think, as you mentioned, there's a private diagnostic element to this. I think within the children's sector, that continues to drive inequities as well. So we see a lot of parents who are able to access private diagnosis in a way that many of our parents aren't. And so I think, as well as that consistency and understanding, the standardisation of that diagnosis is also a real inequity question around that. I really like the report, very, very detailed and covers all the key issues. Two things for me from a children's perspective: mental health support teams in schools. They work really well where they are, and it's a really important thing that we continue to expand and to make that offer to more schools. But it's important that we also keep them within their core scope. And I think where we've seen sometimes they don't work as well as if there's sort of a bit of creep in that scope, and they try and step into other areas and they don't focus on their core activity. So I think that's one thing to keep an eye on. The real challenge around neurodiversity and the pathways, diagnosis, particularly around autism, for me, there is a huge challenge about how we've got to a place where diagnosis and labelling has become the key route to support, and actually we need much more of a needs-led strategy. And for a significant proportion of the children going through the autism pathway, there is potential to look at alternative needs-led models rather than a very detailed, long-winded and often very time-consuming diagnostic approach that actually at the end of it doesn't change anything, because the support that's needed may either already be in place, or we would have known what that support needed to be at a much earlier stage without diagnosis. So I think for many children, and that's where that screening comes in, because we need to know for which children we can take a needs-led approach, and for which children actually that continuation on the pathway through to diagnosis makes a lot more sense. For ADHD, that's slightly different, but I think certainly for autism, that's something we need to look at. And whilst we work through these challenges, the waiting well offer is really critical. So those core component blocks, and certainly what we're looking at in Durham on the back of the SEND inspection, is three blocks of activity. One which is around the needs-led strategy, so how do you meet need without going through the diagnostic pathway? One is the waiting well, so for all of those children who are waiting, what are we doing for them? The point about identification of those with the greatest need and how we manage that, I think, is a really important part of that waiting well offer. And then the sort of clinical diagnostic element, and then how the toolkit fits into that, so we get consistency of screening. So there's a real breadth to what we need to do, and it's really good that we're working with Levi on how we pull that together across the sector. So, but it's a huge challenge.
I think John said it all. I don't think I need to respond to that, Liam.
Thank you, John. Rajesh Nadkarni.
Thanks, Levi. Again, really comprehensive and a really good plan. It wasn't a question. It was just something to reflection on the pilot which you referred to in Whitehaven. I think we've got a real opportunity here, as along with the 5 other national pilots, to make some real impact. So I think the early indicators, the success indicators we'll be looking at will be about, has integration really happened? Are people really getting better? Are we reducing the demand on primary care, secondary care, and the whole system? And what I would suggest is that rather than waiting for the pilot to be, the national evaluation to be looking at these over the next 2 or 3 years, the early successes are quickly looked at and tried to be spread out across the rest of the region, because I think it's a great opportunity. It's the closest we've come to the Trieste model in Italy than we've ever been across in the country. And the other point to make is, we've talked a lot about here about neurodevelopmental disorders, children waiting, and all those, but ideally a community transformation model should have all those aspects together, and that's what Whitehaven will be trying to do. So it would be useful for us to look at the success metrics of that, or even some challenges, and see how we keep on transforming our other services. And the final point, this was a question which isn't there in the report, was I didn't see a lot of reference to eating disorders, when clearly it is a huge issue at the moment in society, in communities, and impacts all areas, and really affects the quality and safety of some of the individuals, including our acute sector colleagues and primary care. So any views you had on that one?
Yeah, and so my get-out clause, Rajesh, was I did describe the report as iterative. And actually at the October Mental Health Learning Disability Subcommittee, we're receiving papers around the current eating disorders and where we go next. So I absolutely think that's something we need to build in this next quarter, a bit more clarity on that offer. Yeah.
Sam.
Thank you, Chair. I mean, the point we discussed earlier in light of the Darcy review and looking at the impact of austerity over the last decade, and here we are sat today with incredibly long waiting lists. I think, Jacqueline, your report earlier was telling us, I think, our longest waiter in our health and care systems just over 4 years. But we also have a waiting list that's increased exponentially over the last 2 years and is showing no sign at the moment of flattening off or reducing. So I think the question we really need to ask ourselves as the board is kind of what's our level of ambition here? Is it treading water whilst the waiting list grows and the waits get longer? Or do we want to go away and do some further work? And if we are to have parity of esteem, and if we take elective care as an example of that, go away and do the work and say, actually, if we wanted to put in exactly the same standards that we're holding ourselves to for elective recovery at the moment for this particular condition for children and adults, what would the scale of the investment look like? And my view is I think we need to do that work to inform our commissioning intentions for the year ahead, and as a board we should receive an update on that at our next meeting.
Jacqueline.
Thank you, Chair, if I may. I mean, I just wanted to say I couldn't agree more, and I think it's great to receive the report, Levi, and there's some really well crystallised plans there, but my reading of it, I think, was that your last point is very important, that focus on the investment profile, that all of the plans that we've got are not in themselves going to get us to the position we'd want to see for our patients who are facing these challenges. And I wanted to add in talking therapies and come back to the point I made earlier. It's not measured in the same way around that 104-week wait, but it's another area where for the last 2 years our plan as an ICB has not met the national ask, and then we haven't delivered our plan. So it's another area where we're not investing the levels that we need to. There's more investment in this plan that Levi's brought to us this afternoon, which is great to see, but there's still a significant gap there. So it's another area where I think we have to critically examine our ambition. Thanks.
We've got some decisions to make before we sign off on this item, and we're running 10 minutes late now. But Levi, I just wanted to ask, you and I had a discussion about a month ago on the question of the size of the backlog of assessments, and other people have commented a bit on this, but we did have a discussion about broadening the number of people who were regarded as being competent to carry out assessments, and particularly talking about the potential role of parents even in that, using properly standardised tools. I just wondered whether the thinking on that is any clearer, or any concrete ideas coming out of it?
This does go a little bit back to the Portsmouth model and opportunities there for, it would not be the same obviously as a formal diagnosis, but the point is about identifying the dimensions of support that people need, which if you take the 10, without going into a lot of detail today, the 10 aspects of emotional regulation, for example, strategies for managing that in a much more different way that don't require the formal diagnosis. In the last few weeks, we have, with some slippage on some schemes, we are putting an additional resource, particularly into children's, about 1.4 million this year, to create some additional capacity to get through some of the backlog. But as others have said in the room, that isn't going to clear the waiting list, but that's the intent, is to get some of the backlog through, redesign the pathways so that the initial offer is more streamlined.
Thank you. Right, so we're asked to approve the improvement plan, including the next steps in Chapter 10, recognising that it's not yet complete and will evolve. Secondly, to note the widespread, consistent and entrenched performance challenges, consider any further approaches to addressing those challenges. We'll do come back to individual members of the board want to come back with suggestions. We would very much welcome that. Note the increasing waiting list and waiting times for children's neurodevelopmental assessments and adult autism and attention deficit and hyperactivity disorder assessments, and approve that during the 2025-26 operational planning round, a high level of focus will be given to ensuring the parity of esteem, at Sam's point, in meeting mental health, learning disability and neurodiversity performance standards. Are you okay with all of that? Good. Okay, thank you. So yours is the next item as well, Levi. If you can catch up a little bit on the time. That was a very interesting discussion, which we didn't want to shorten, but we just need to keep an eye. We've got visitors coming to talk on the Poverty Commission in a little while.
I should be able to keep this brief, Chair, as we'll be bringing in a further update at the next meeting, but we wanted to make sure the board was cited on the National Mental Health Intensive Treatment and Assertive Outreach Review. We've talked previously about the Nottingham events and the review at this meeting, and myself and Rajesh Nadkarni will be bringing a more detailed presentation to our October board development session about some of the local response and lessons learned and how we've been taking action in the North East and North Cumbria. However, there was a requirement from NHS England for all ICBs to oversee a service review. That was due for submission on the 30th of September. Our return did go in within the deadline. It had a number of criteria that we were asked to review with our main providers, but also our acute FTs who provide mental health services. It included a group of Foundation Trust reps, our Association of Directors of Adult Social Care, Provider Collaborative, people from the voluntary sector and individuals and carers with lived experience. It asked a number of questions around services, policies and approaches. And from that, what we'll have initially identified as some themes of where we think we've got some good practice, what are some of our gaps, and those gaps are primarily around caseload size, workforce capacity and experience, and refining pathways for the future. So we've submitted that to NHS England. They're going to do some work reviewing those collectively and they will feed back. But we're going to start in the next fortnight is our focus on our local action plan. But again, we can update board on the detail at a future meeting.
Any questions or comments for Levi on that? Okay, so on this one, we're asked to delegate the authorisation of submission to NHS England to Levi in discussion with other executive directors where necessary. Are you happy with that? Good. Okay, thank you very much. David Perdue, now over to you for the item 17.2.
Thank you very much, Liam. So this is the annual learning from the lives and deaths of people with a learning disability and autistic people, which is shortened to LEADER. So this is the annual report from January to December 23. And the board's here to present this along with the Learning into Action report and the easy read version. So in terms of the LEADER report this year, we've changed the reporting cycle to fall in line with NHS England, which is a calendar year rather than a financial year. And through that period of time, there were 257 notifications to the National Leader platform about people with learning disability and autistic people who've died within North East and North Cumbria during 2023. So in terms of reviews, 216 reviews have been carried out, 26 of those focused. Of these, 216 were about people with learning disability and 8 were about autistic people. The remaining will become an appendant to this report. So, as usual, the most common causes of death during 2023 have not particularly changed, were pneumonia, aspiration pneumonia, heart disease, respiratory disease and cancer. So it's really important in terms of the significant learning points and actions is that through our changes with 2.0, we had an opportunity to centralise, streamline and standardise leader across North East North Cumbria, with a Learning Disability Network joining us from the 1st of April to provide the strategic leadership across all elements of the programme. So we continue with some similar themes in terms of notifications of autistic people who have died has remained low, and NHC nationally are working on an awareness raising campaign, and a NENC awareness raising campaign will be undertaken. And then in terms of notifications from people from ethnic backgrounds has remained low. So we now have a lead identified within the LEADER programme, and the work is embedded within the ICB Health Equity and Inclusion programme, and awareness raising campaign has been delivered. One of the key things is about how we get more information to understand the quality of care received by people with learning disability and autistic people. So in terms of the focus reports, we do look at kind of the quality of care, which is rated from 1 to 6. So of the 26 focus reviews, only 6 gave a good standard of care, then 8 gave an adequate standard of care, and then 12, unfortunately, gave a standard of care which was below what we would expect for people. And some of the key areas around there was kind of the understanding of Mental Capacity Act within our acute providers. One of the other key things from the reading is looking at where people actually died, and a majority of people died in hospital. So there's some work being undertaken to look at end-of-life planning for people with a learning disability and autistic people to ensure they understand kind of the different elements of end-of-life, including not for resuscitation. One of the key changes is now kind of we have a learning interaction group through the ICB, and they've looked at some particular points. So one is around reasonably adjusted NENC winter vaccination programme. There's been an awful lot of work on hypertension case finding, and then be screening aware and be cancer aware peer education. Then we've done lots of work around annual health checks, but ensuring that people understand annual health checks, especially around breast and bowel screening programmes, and the recommendations from those have gone to the programme boards. We've also looked at annual health check prompt sheets, and then, as Levi said before, we have a really good reasonable adjustment campaign across NENC. And then one of the key things I'm finding that's going to be a focus this year is actually looking at people not brought strategy. So kind of that is people with a learning disability and autistic people not attending appointments. And it's not just as simple as they did not attend, actually these people are not brought. So we need to do far more work into understanding kind of what are the blockages for that. And that will be a key piece of work this year. And also looking at kind of research and education. And obviously we're looking at the rollout, through this group, we're looking at the rollout of mandatory learning disability and autism awareness training is underway through the Oliver McGowan training. Happy to take any questions.
Thank you. Open it up to questions and comment. Do you get the impression that these reports around the country are making a difference, David?
I think we're doing some really good local work. I think nationally there's work to do on kind of the reports and how the focused element is undertaken. So I think there's some really key piece of work that we need to share learning across, which I don't think we do as well as we could.
Yeah. Okay, thank you. Oh, sorry. Oh, yes, Anne Fox. Sorry, I was trying to work out whether that was Tom next to you that had his flag up. But go ahead. Yeah.
That's okay. Thanks, Chair. I just think it's important to say we've always worked very closely with the Learning Disability and Autism Network. But I think the fact that the team are now embedded within the ICB has really strengthened their impact. So we've really been able to join up the learning that we are deriving from the leader process and the activity of the network into the clinical strategy that Neil talked about and the work that Levi's doing. And obviously we couldn't do any of that without the voluntary sector involvement that we have from Inclusion North and Stop People Dying Too Young group, and the experts by lived experience who are absolutely embedded in the governance processes. So I think whilst as you quite rightly ask about impact, I think we are seeing impact, but there's an awful lot more to do, and I think an awful lot more awareness raising about the leader process as well. But I think the team now and the activity is perfectly positioned to be far more influential, I think, for the future.
Thank you very much. Well, the next item is one we've been looking forward to. We had to postpone it because of the election, but I'd like to very warmly welcome Right Honourable Baroness Hilary Armstrong of Hilltop. That's her full title. I think of her as Hilary, and we've had a lot of contact over the years. She's a daughter of the North East and has done fantastic work to promote the status and influence of the North East through all her roles. She was a cabinet minister in the previous Labour government, and in this capacity she's with us today as chair of the North East Child Poverty Commission Project Advisory Group, and accompanying Hilary is Amanda Bailey, director of the Commission. So before handing over to you to talk about your work, I think Sam Allen, our Chief Executive, is just going to say a few words of introduction.
Well, just to say, Liam, welcome you today. Giving children and young people the best start in life is one of our 4 goals in our integrated care strategy. It matters to us deeply, and in fact the topic of child poverty has come up right throughout the whole of our board meeting today. So we're delighted to welcome you, hear more about the work on the Commission, and also I think for us as a board to explore more about how we can get involved, what our responsibilities are working together with our partners.
If I can just say thank you for that welcome. You can see I've been at this for a very long time. I had hoped that we'd made real inroads into tackling child poverty, and we had in this region, but it has now gone back significantly. I've had the pleasure and privilege of working with Amanda. She's the one who does all the data, who gathers all the information together, and who actually makes it, does the detail. So Amanda's going to go through some slides with you, and then I'll sort of wind up, as I always would, giving the broader questions, the broader issues, and where this ICB sits, exactly as Sam is saying, in the development of a more robust economic and social environment for families in this region, so that they can all have the opportunities that they deserve. Amanda.
So thank you again also for inviting us. We really appreciate the opportunity to come and present this work and discuss it with you. As you've said, I'm Amanda Bailey, the Director of the North East Child Poverty Commission, and again really glad to be joined by Hilary today, who helped to chair and inform the advisory group which shaped the report and the research that we're come to speak about today. Oh, God, my first slide. For those of you that don't know us, the North East Child Poverty Commission, we're not a charity, but we're a cross-sector network of organisations from right across the North East region. So the 12 local authority areas from Northumberland down to Redcar and Cleveland, not including North Cumbria, sadly, which I know is your footprint. And we're hosted by, but independent of, Newcastle University, and all of the organisations involved in the Commission are jointly committed to working together to tackle child poverty in the North East, with the Commission providing a forum through which to do that. We aim to influence policy and practice locally, regionally and nationally, and we start from a really important collective position, that is, child poverty in the North East is not inevitable, and ending it is worth working for together. That shared view is absolutely central to everything that we do, despite the scale of the challenge that we all know we face, and you're all well aware that we face. And really importantly, because we're always acutely aware that this issue can feel absolutely overwhelming, we know that there are actions we can take locally, regionally and nationally to make a difference on this issue. So that's exactly what we tried to set out in the report that we published in February. We published it then ahead of the combined authority mayoral elections that took place for the first time in all parts of the North East region in May. Obviously, it was also and published before the general election that took place in July, and things have moved on somewhat nationally since then. But the reports and the recommendations that we published were based on a year's worth of research across the region. We held conversations with over 150 different organisations across all sectors, including the NHS and the wider health system, as well as conversations with parents and carers and young people themselves, again across the region. We started with the question, if we were to have a child poverty strategy for the North East, what could and should it look like? And the final report, or what we described it as a blueprint, is entitled No Time to Wait, because we feel quite strongly that nobody gets a second childhood. We all know that what happens in your childhood can influence the outcomes throughout the rest of your life. And I feel really strongly, and I think the wider Commission does, that children and young people here in the North East, frankly, don't have much more time to wait for meaningful change on this issue. So, to give a really brief summary of what was a 100-page report, and there's a link on the slide, which I assume are going to be shared with everyone, we tried to make the case in the report for using the opportunity of devolution, which we see as a big opportunity, to just take what we described as a public health approach to tackling child poverty as a priority, and to tackling the underlying structural drivers and causes of child poverty as opposed to alleviating the symptoms. We argued that should be convened and coordinated and driven forward by our mayoral combined authorities, but it has to be a collective effort in which organisations across all sectors, and particularly our anchor institutions and especially the NHS, should pull together and play their part. The report sets out what we described as a blueprint for what an ambitious and solutions focused, that's really important, coordinated cross-sector regional action to tackle child poverty could look like. And we identified 4 strategic priorities for that work, which I'll come back to later. And all of that was absolutely grounded in the quite significant amount of quantitative data analysis that's included in the report, as well as lots of new qualitative data analysis, which I'll come on to as well. So, turning to the new quantitative data analysis, including the report, which we either did ourselves or we did in partnership with lots of different national organisations like Child Poverty Action Group, Joseph Rowntree Foundation, the Living Wage Foundation, Action for Children, many others. I thought it'd be helpful to highlight today some of the key new findings from the report. There are many more included in the full report. I don't have time to cover them today. For example, around the inequalities that exist within the region and the really stark differences in child poverty rates at quite a local level. Also around the scale of in-work poverty. But some of the key new findings include, one of the things we looked at was the depth of poverty for children in the region. We know and we can track how many children are living below the poverty line. That is children who have less than 60% of UK median household income. But that information alone doesn't tell us much about the depth or scale of child poverty for children in the North East, or how intense the level of hardship they're likely to be experiencing. We therefore work with the Joseph Rowntree Foundation to identify what actually that looked like in the North East. So we know that around 1 in 3 children are living in poverty or below the poverty line. But what we also found is that around 1 in 5 children in the North East are living in what's described as deep poverty, and 1 in 10 children are living in very deep poverty. Those rates are interestingly the same as across the UK, so as the UK average. But the reason they're concerning for the North East is that in most other parts of the country, deep poverty and very deep poverty are driven by very high housing costs, which we do not have in the North East. We have the lowest housing costs across all housing tenures, social, private rented sector and owner-occupied. So the fact that we have the same levels of deep poverty and very deep poverty and we don't have those high housing costs is the concern for the region. And obviously it's really important that we think about what the immediate and longer term impacts of that are for children's mental health, physical well-being, both immediately and longer term. We also found that around 1/5 of North East children are living in households that are food insecure, which in the government's definition means they do not have access to sufficient food to facilitate an active and healthy lifestyle. That's the highest rate of anywhere in the UK. And again, there are some pretty serious immediate and longer term health implications of that. And we also found that around 7 in 10 children in our region are living in families that have zero or little savings to protect them from economic shocks or unexpected bills. So something like an essential item like a washing machine or a fridge or a cooker breaking down can become a disaster for a family. And it's that lack of financial buffer that we heard about time and time again, or resilience, which is a huge issue for children and families in the North East. Again, that's the highest rate of anywhere in the country. And then finally on this slide, we worked with Action for Children because they've been undertaking some work nationally about the proportion of children in poverty across the country who are living in what they describe as work-constrained families. And that means families who face at least one significant barrier to boosting their income through work or by taking on extra work. That could be families where at least one person has a disability or a long-term health condition, someone who has unpaid caring responsibilities, or where parents and carers are already in work and therefore trying to boost their income through working more is quite hard when you're working full-time. They found that in the North East, around 63% of children in poverty are in work-constrained families. And it's really important to think about that when the only strategy really for reducing child poverty that we've had nationally over the last decade has been that focus on parental employment. When you can see them, almost 2/3 of the children in poverty in the North East, that's not going to be the only route out of poverty. And it's really important to emphasise that analysis by Action for Children not only draws on nationally produced government data, and they say themselves there are likely to be many other work constraints that families face, and one of the really key things we identified in our report was the issue of our public transport system across the region and how that creates an absolutely massive barrier for many families in being able to access economic opportunities, education, leisure, support services, and of course health appointments. So alongside some of the quantitative data analysis included in our report, there's also a lot of qualitative research, as I said, based on all the conversations that we had for the research. And in the report, we identified 4 key themes that emerged from our conversations. Firstly, the absolutely vast amount of time and energy and capacity and resource that is now focused on dealing with the impacts of poverty and crisis every single day by organisations across our region, whether that's schools, colleges, the NHS, community organisations, youth clubs, sports groups we spoke to, that came up over and over again, and including obviously the enormous number of charities, whether that's food banks that we have allowed to become normalised over the last decade, all of whom spending a huge amount of time and effort and resource on dealing with the immediate symptoms of poverty every day. I'll give you just one example of those charities being the Baby Bank that's based in Sunderland. I think you visited recently, Love Amelia. They were established in 2019, since when they have provided 19,000 support packages to local families, all of whom are referred to them by statutory services like midwives, like health visitors, like social workers, but all of which is being funded through charitable donations. Secondly, we highlighted just some of the astonishing ways in which parents and carers affected by poverty themselves are supporting their communities in a way which I think is completely invisible, is not recognised or valued, and is masking the true depth of hardship for communities. I think that work's really important, but it really is taking place in quite an invisible way. We also looked at the way, or heard over and over and over again about the way in which low-income families can be treated by the system and the lack of understanding that many organisations have for people's circumstances. I lost count of the times the word degrading was used during my conversation with the parents and carers and even young people about the way that they are regularly treated across all organisations. But finally, and much more positively, there was a really clear and collective agreement from almost everyone we spoke to that tackling child poverty has to be a regional priority. And again, as I said, that has to mean tackling the structural drivers of poverty and the root causes, not continuing to try and alleviate the symptoms and firefight every day. And many of the, almost all of the organisations we spoke to wanted to play their part in that. So finally from me, as I mentioned, our report identified 4 strategic priorities for action that were totally grounded in the research, and underneath which sat several actionable recommendations, with just some of these included here on this slide. So the very first priority that we had, and we chose this quite deliberately as being the first one, was around maximising family incomes now. It was incredibly clear to me through all of the conversations that we had that we have to do everything we can in the region to at least try and stabilise families' income and ensure that their income is maximised as much as possible. We worked with the National Organisation Policy and Practice to estimate the value, for example, of unclaimed support across the region, so that's social security, but also things like social water tariffs, broadband, and they estimated that the annual value in the North East is £1.3 billion a year of unclaimed support. So even if we use every lever possible to try and make sure that families are receiving what they're entitled to, that would make a difference. And there's already quite a lot of really positive work taking place on that. For example, the North East Combined Authority have just agreed to fund an extension of their welfare rights in school work. There are a number of local authorities across the region that are now implementing an auto-enrolment scheme for free school meals quite successfully. But I guess the question is, what part could the NHS play in all of this? Is it about signposting and making sure that every single person who comes into contact with the family is aware who they can signpost people to? Is it about having this kind of activity within health settings? I know that Citizens Advice Gateshead work with, I think, Newcastle Hospitals Trust to ensure that that support is available to staff and I think possibly patients within their hospitals. And also, is there scope for some of this work to be funded through the NHS, given the very clear health benefits of families not living in a cold, damp home, of being able to afford healthy food? Our second priority was about making a route out of poverty. We know that, like the rest of the UK, the majority of children in poverty in the North East are in working families. That proportion is not quite as high as the UK average, but it's still the majority. And we know that the North East continues to have the lowest weekly wages of anywhere in the country, an issue that we absolutely have to address if we have any hope of improving health outcomes across the region. And so one of our main recommendations around that was getting our 2 combined authority mayors to commit to making their areas living wage places. It is notable that there are only 2 NHS trusts in the region that are accredited living wage employers. I think there are about 30 across the country. But I personally feel that this is a really, really critical part of the role the NHS has to play as probably one of the single largest employers in the region. Health and social care, that your role as an employer is as important as anything else you might do. Our third priority was around the best start in life for the next generation, so really thinking about how we collectively invest more in our region's future. That is the babies, children and young people growing up here today, and some of our recommendations included expanding free school meals to all on universal credit. That's at primary, secondary and college age as an immediate priority. We did suggest, given that resources are limited, that organisations across the region might want to pool resources to fund that, including potentially the NHS and ICB. I firmly believe that expanding free school meals is a health policy as much as an education policy. We looked at things like expanding the baby box scheme, which I know is being rolled out in quite a small way currently to vulnerable families across the region. Again, clear health benefits of that. And then we also talked about creating something like a North East Youth Guarantee with lots of different recommendations under that. But one of the things we included in that was organisations across the region offering meaningful poverty-proofed work experience for all young people, so that we increase the opportunities available to children, young people, particularly from low-income backgrounds, who don't have networks, who aren't able to easily access work experience to get their first foot on the ladder. I think that's something the NHS is ideally placed to do, and it's something I know, for example, the NHS Business Services Authority have been doing in Newcastle. And then finally, our overarching priority, if you like, was about securing a region-wide anti-poverty commitment. So organisations across the region committing collectively to do what they can to tackle this issue as a priority. And we looked at things like adopting the socio-economic duty of the Equality Act to inform decision making, including things like recruitment practices, thinking about how organisations can use their procurement or commissioning to tackle poverty and inequality. We looked at poverty proofing. I know that's being done in a small way in services across the ICB, but really that should be a matter of course. And then finally, and this is perhaps controversial, is the role of national advocacy. I alluded earlier to the fact that national government and the new government have committed to have a new bold cross-government child poverty strategy. But what is the role of the NHS regionally in advocating on that and the importance of that new strategy being really meaningful and improving the living standards of children and young people now, which is urgent, given the impacts that this is having on all of your work and resources. And so in conclusion from me, I think our main message is we simply can't keep managing the symptoms of childhood poverty in our region. We have to start treating the causes. And we think the NHS has a significant role to play in that.
Okay, I simply want to reinforce what Amanda has said, but particularly in relationship to the legal, if I remember rightly, from when the bill went through, reasons for ICBs, what you were established for, and what I know, because Liam and Sam know that my husband is somewhat involved again, despite us being in favour of, we are in favour in the new government of encouraging more people into work. I wasn't sure about 76-year-olds, but never mind. He's there and in the department at the moment. But I know that in this region in particular, we have specific details about why families are not prospering and not doing well. You know, you look at our history and it's easy to see. You know, I was born in Sunderland. My grandfather, who lived with us, was a boilermaker at the shipyards, the elite. My other grandfather had been a miner in County Durham and died of the dust. We had that traditional way where everybody knew what was expected of them, what was going to happen to them, and therefore what they needed to prepare for when they were at school and so on. And that has gone totally. And it is in those areas of post-industrial decline that we have seen the greatest effect of child poverty. And of course, we also know that those industries and the environments of those industries brought health issues. And now poverty brings health issues. So it is not an accident that you have more children with diabetes in this region who end up in hospital. You have more children with asthma in this region who end up in hospital. So the physical demands on the health service from these levels of poverty and disadvantage are very clear, let alone all of the other social and mental health issues that arise from these levels of disadvantage, of inequality, and of poverty. Now, I know that the health service, in a sense, has never been seen as the agency that will have the most effect on this. But we are called a national health service, not a national ill health service. And what ICBs were asked to do, and I've got to get back to the notes, is improve the outcomes in population health and healthcare, tackle inequalities in outcomes, experience and access, enhance productivity and value for money, and then fourthly, help the NHS support broader social and economic development. And actually, it's three of those four that we're talking about today. 3 of your 4 main imperatives as an ICB are actually about what can you do to motivate the National Health Service to be an active partner in tackling what to me seems the most pressing issue in this region. Now, I know that you'll be given challenges on waiting lists. I heard a little bit about that in one of the earlier items, and so on, and getting those down, of course, because that too is an issue about access and so on. But unless we are able to lift ourselves out of the terrifying things that are going on within the service and see what is affecting the service, see the context within which the NHS is trying to work, you will never be able to sort the internal issues out without those issues of prevention. And I know the new government is talking about prevention. They don't mean what I always used to mean when I was social exclusion minister, which was actually, you know, I did all of those things around what we then called the Family Nurse Partnership, and those very early intervention programs, which would absolutely have made a difference to all families by the time the child was 6. But, you know, it was seen as too expensive. So we had a couple of programs in the North East, and they've disappeared. But this is about how do we prevent things just becoming worse for families, whether that's at the old age end, my end. How do you keep people like me active for longer so as we're not ending up a drain on the NHS? And how do you actually, as you say in your strategic plan, help to make sure children are school ready? We are saying to you, think about the living wage. I gather that about 3,000 people have been brought into the living wage in the Newcastle Trust. Now that is a real challenge for them, I appreciate that. But unless we can really get underneath these problems at a level that mean people will, you know, if you give an extra, about, what is it, just under £2 an hour to move to the living wage for the poorest paid in the National Health Service, they'll not spend that money on skiing holidays. They'll not spend it going to Malaga for their summer holidays. They'll spend it in their local community. They'll be buying food, and we've got to encourage them to buy better food and to buy food that will be nutritious rather than harmful. That's why we've spent, we wrote to every local authority about the auto-enrolment for free school meals, because about 15% of kids who are eligible don't get free school meals. And the previous governments have been saying to me for ages, oh, it's data protection. I got it from the Information Commissioner, no, if there are vulnerable children included, you have a responsibility to help them, not to say we can't because of data protection. So now we wrote to every authority once I'd had that sort of clearance nationally, and every authority is now taking that up, which is fantastic. But what we've now got to do is spread that a bit further and make sure that the meals they're getting are nutritious. When they did this in Finland, because they had the highest death rates from stroke and heart attack, because they were protecting themselves in the winter extremes in Finland, they introduced compulsory free school meals throughout the system, and alongside that, cooking lessons in schools for every child, where they taught them how to make nutritious meals. They are now one of the top 2 countries in Europe in terms of lowest heart attacks and strokes. So that is why Amanda will say this is a health issue as much as an economic issue. But if we get the two working together, we can make a huge difference. Now, I can go on forever, but I've already talked too long, and I'm sorry about that. I do feel passionate about that. And I just wanted to make sure that you have an idea going out of here what you can do as an ICB to help this region transform opportunities for children and young people growing up. Thank you.
Thank you. Thank you to both of you. Claire Riley. You better maybe people could say who they are, because Hilary and Amanda won't know everybody.
Thank you, Baroness Armstrong and Amanda. My name is Claire Riley. I'm Chief of Corporate Services for the Integrated Care Board. And I met you quite a number of times in a previous life, Hilary. It's really encouraging to hear your presentation, which was excellent. I think there's multiple opportunities to align your work to some of the work that either we're already doing or planning to do. I think it links very firmly in with the Better Health and Fairer Health work that is led by Neil. It also aligns very closely to the work that we are really starting to ramp up around Anchor Institution and the responsibility of NHS organisations to their local communities. So I think there's a lot of opportunity there. We're also doing quite a bit of work around work and health. And I think that aligns firmly, and it also links to the combined authority too. And I just think there's an opportunity to map this all out, to really look to see how we can join the dots on some of this work. And one final point around eligibility for benefits or support. I met with the BSA yesterday about that, and we know that not enough women, for example, are taking up the MAT-B1 form and things like that, and we are really keen to support and amplify the message around eligibility across our communities. So again, that is definitely something that we can support, and the reach the NHS has, not only through trusts but also through the ICB and also through GP practices, is quite vast. So that's certainly something that we could support too. But I think overall, maybe meeting up to just map out those linkages, how we connect into the work programme would be really helpful. Thank you very much.
Thanks, Claire. Lisa.
Hi, I'm Lisa Taylor. I'm the voluntary sector representative. Thank you. And I just wanted to say thank you so much for your fantastic presentation, highlighting the important work that you've been doing that absolutely underpins everything that the ICB should be doing. And my question was going to be to the ICB board about how they can link in, but Claire has actually covered that really well, and I feel proud to be part of a board who's taken everything on so well. I do have one question though. I'm just wondering, is the ICB itself a living wage employer? And if not, are we able to move on that?
It's a really good question. We aren't technically a living wage employer, but I don't think we'd have any problem signing up to become a living wage employer, and I'm happy to commit to do that today.
Thank you. John Pearce.
Thank you, Chair. Yeah, I'm John Pearce, Director of Children's Services in Durham. I'm one of the LA partner reps. So, I mean, the work of the Commission is amazing. I think it's fantastic. And certainly on my travels nationally, I've been pointing everybody to the various reports that the Commission does when we've been talking about child poverty. I think the point around benefits is really interesting because it's often the gateways as well. So as an authority, we've implemented the auto-enrolment for free school meals. And it's not just the benefit of the additional access to free school meals, but actually it's going to bring about £3 million extra into our schools through pupil premium. So all of the sort of spin-off effects of that. But ultimately, working in children's services, we spend every day dealing with the consequences of the context in which our children and families live and the consequences of child poverty. And that's the case across social care, it's the case across health, it's the case across education. And ultimately, we're going to continue to see demand escalating unless we address child poverty in a really meaningful way. And it's important we come together as a sector to enable us to do that. And all of the things we talked about earlier in the meeting that came out of the Darcy report, about that rebalancing, about moving from illness to prevention. We can only do that by really tackling the wider determinants, and this is such a critical issue in terms of the wider determinants that I think it's essential that all sort of major bodies within the region take this on board, because it's a huge national issue, but it's far more of an issue in the North East than sadly than it is in many other places.
Thanks, John. Rajesh Nadkarni.
Thank you. Thanks. I'm Rajesh Nadkarni. I'm the a partner member with mental health expertise. I mean, first thing to say is thank you for the presentation, but what is really good is the clarity and simplicity of the ambitions. So the 3 ambitions which you talked about, and I suppose what we could do as an ICB board, along with all our partners in the ICS and now with the 2 combined authorities, is to see what we can do within the organizations we work to make an impact on those 3 priorities. And some of them could be that we have some active role, some might be an indirect role. But I think they are quite simple, they are quite impactful, and actually that does work through what you were saying towards our prevention agenda. Because if we give children the best start in life, you know, then we've solved it for the next 10 or 15 years. Thank you.
Sam.
Thank you very much, Chair. I just wanted to ask a question around kind of what do you see as some of the biggest barriers that gets in the way of us making progress on this? So we've spoken a lot about the Darzi report today, and obviously the kind of the impact of austerity over the last decade. Yet when you also look at the amount of resources going into the public sector, we could do a lot more with what we've got, and I'd be really keen to kind of get your insights into what you think are some of the things that get in the way. And then just the points about Cumbria, you mentioned that you're not covering Cumbria. We're actually in Cumbria later this week for a health summit in Cumbria, so we can certainly take the recommendations from this into that conversation. And I just wondered again if there'd been any further conversations with Cumbria about them joining forces on this.
Not in relation to Cumbria, because our footprint is the old North East region, like a number of other organisations, and I am our only paid member of staff, and there's a limit to the geography that I can cover bluntly. But I think the challenge, and it was clear throughout all the research, is that organisations are spending so much time dealing with crisis and firefighting that it's really hard to stand back and do the strategic stuff at the same time that you're also still having to do the crisis stuff, whether it's children's social care, whether in schools, colleges. I was quite shocked when I spoke to colleges around the region about the level of hardship they're seeing with their students, youth organised, all the different groups that we spoke to. So I think that's one of the big challenges. I also think there is absolutely no shortage of people. There are literally thousands of people across the North East alleviating the symptoms of poverty every day. The challenge is how we do the longer term structural strategic stuff whilst also doing the crisis stuff, and trying to coordinate that so that we're not duplicating scarce resource. And as I said, one of the things we talked about is how do we genuinely use devolution as an opportunity to think about how do we pool resources in the region if we're all working towards the same thing, to really decide as a region. Because my vision is we get to the point where people say, wow, look at what's happening in the North East, what can we learn from that region, as opposed to what's normally the case. So, you know, let's use the North East as a test bed to really try out new and different things. And some of those things won't work, but until we try them, we won't know. And also, it's helpful that you found that the sort of priorities and ideas is relatively simple and clear. There is a lot of stuff in there that is quite ambitious. I am well aware that the idea of making the North East a living wage region is ambitious. But unless we set ourselves those ambitions and then work out how we're going to get there, it is not going to happen. And we're going to be having the same conversations about the North East in 30 years' time that we've been having for the last 40 years. We have to decide that we're going to do things differently.
Yeah. Oh, sorry. But this region is far more dependent on the public sector than other regions. I sort of did all the stats about this at one stage when I was the MP in North West Durham. But, you know that's true in the health service, in education, and so on. People are far more reliant on the public services, but that then meant austerity had an even bigger impact. And so it is about how we work together effectively, which is why you are so important, because you, Integrated Care Board, it means how do you work alongside other partners, other organisations as partners in this journey, because you know I can't even remember the proportion now, but there is a there's a frequently told percentage of health that the NHS can actually affect, and it's about, what is it, 25% or something. You cannot get a healthy person without everything else coming together. That if you're treating somebody for asthma and they live in a deeply flawed property where there's mould and damp and so on, whatever you do in the NHS isn't going to sort that. But what we need to do in this region, partly because we have a bigger public sector than elsewhere, is get that public sector working together more effectively and with a bit more trust. And that is difficult, I know. You know, I've gone on about this all my career, you know, I know how difficult it is. But I remember as well that means we have to recognise that in order to get equal access to services, you've actually got to try harder in the areas where people are most deprived. And the person who ran the social exclusion unit that I worked with very closely, certainly in my first 5 years in government, she said to me later, "You've all forgotten, but we actually made mainstream budgets. For the first spending review, mainstream budgets had to look at how they made sure that areas of disadvantage didn't be further disadvantaged by how we put the money out." So we had that there had to be cooperation across government on mainstream budgets funding in a way that meant you couldn't not look at areas of deprivation. That still didn't mean everything worked well, but it did mean that happened. And I'm now trying to remind members of the government that we did that before. That was all undone. Haven't even renewed the index of multiple deprivation, which I was part of introducing, since 2019. So we don't have the granular information that we need. So I'm hoping they're going to do that again. But it is, how do you combine budgets to make sure that at the end of the day, the outcome benefits the person as well as the community they live in? And we sometimes forget that regeneration is essentially about people first and foremost. And yes, they need the infrastructure. Amanda's absolutely right about transport. Huge issue in Cumbria. How people get to school, to college, to work, to health care. Huge issue. And hopefully once we get buses, you know, the problem is expensive, not much money there, but getting better bus services outside of London is absolutely critical. So, you know, it's working together.
Thank you. Tom, maybe this should be the final point.
Yeah, and thank you again both. I suppose I was just picking up on Sam's challenging question, really, because I think there is definitely something about how as an ICB, we can lean into the system work, and not least within the devolution footprints and the announcement of the child poverty unit for the North East Combined Authority. And Sam, I know you were kind of part of that launch as well, weren't you? So I think it's really important that we play the system part. I think picking up your question though, if we were to hold ourselves to account on it again and think, well, okay, so what would a poverty what would poverty-proofed healthcare look like, for example, within our ICB? So you picked up the point around travel. There is the healthcare travel scheme. Do we maximise that? Do we make the most of that, where people on certain benefits are entitled to free transport to and from NHS appointments? Do we think about how we offer appointments and when we offer appointments for people who are on lower incomes and maybe can't drop an hour to nip to the GP or go for their diagnostic appointment, whatever it happens to be? So if we were to think about what would a poverty-proof NHS look like for the North East, North Cumbria, could we set ourselves a vision that then can help contribute to the wider system piece? That is a specific action we can maybe take away from today, and I'd be really keen to be part of some of the discussions on that.
Okay, thank you. Well, we have really enjoyed having you here, and the discussion, as I say, we planned it quite a long time ago, so it's great to have been able to bring it together today. And it doesn't need me to be a very good reader of body language to notice how inspired and galvanized everybody was by listening to you. So we're all on the same page. And I like it that, Hilary, you reminded us of our moment of creation, our birth, and that this is really in our genotype. And we now have to work out how to express the phenotype and make it reality and concrete action, which we, in a powerful position as the NHS and local authorities working with us and the other partners, can do. So I think what we will pledge to do within hopefully a matter of weeks is to come up with a plan of how we see the connections in practical terms, and then we can start to work on them. But thank you very, very much for today, and we greatly support you in everything you're trying to do. Okay, and then you can stay put, because this item, last one, is just for information. Claire, items that have been submitted by the public.
Thank you, Chair. We've received 2 questions from the public, not directly relating to agenda items. The first is linked to Tier 3 weight management, and a response has already been provided. Another one links to an issue with a GP practice in Tees Valley, and we are dealing with that separately.
Okay, thank you. So that concludes the meeting. Thank you, everybody. And we look forward to seeing you at the board development event, which I think the next time we're getting together. Thank you.